Council and the members of the College of Chemical Pathologists, medical officers of pathology and other medical officers. Good morning to all of you. I warmly welcome all of you to the second day of the workshop for medical officers in pathology organized by College of Chemical Pathologists of Sri Lanka. I take this opportunity to talk a few words about our college and chemical pathologists in the country. Our college is a very young college, established about 7 years back, and currently we have about 100 members. We as a professional organization dedicated to the advancement of clinical chemistry and the laboratory medicine in Sri Lanka. There are only about 25 chemical pathologists serving currently to the country, and I'm happy to say that we have covered all the provinces and most of the districts in the country. Few of those chemical pathologists will talk to you today, and I warmly welcome all those speakers to this workshop today. Without your contributions, we surely would not have been able to make this event productive to enrich us all. I welcome all the medical officers who have joined with us today for the second day of this workshop. I hope you had fruitful first day of the workshop and you maybe gained some knowledge which you can apply in your day-to-day work in laboratories. We have already uploaded the day one lectures to our college website, and if anybody who missed the day one lectures can listen to those. Dear participants, your presence is an immense encouragement to all of us. Chemical pathology is progressing rapidly as a specialty with highest impact on medical decisions, and you all are part of that specialty by involving chemical pathology services throughout the country. Today also you will get the opportunity to listen to the chemical pathologists with many years of experience, and most of the topics are very common to you all. I'm sure that this will be a valuable experience to you all. Thank you.
Today's program will commence with a lecture on diabetes mellitus. We warmly welcome Dr. Tushara Hewagiganage, Joint Secretary of CCPSL and Consultant Chemical Pathologist at Teaching Hospital Anuradhapura, to deliver his lecture on role of the Chemical Pathology Laboratory in screening, diagnosing and management of diabetes mellitus. Over to you, sir.
Thank you, Dara, and good morning, everybody. I will continue having my video switch off as my internet seems to be a bit unstable today. Right, thanking the College of Chemical Pathologists for giving this opportunity. I will straight away get on to the topic: role of chemical pathology laboratory in screening, diagnosis, and management of diabetes mellitus. In this lecture, I will be talking about diabetes mellitus in view of its definition, classification, prevalence, screening, diagnosis, and follow-up. Diabetes mellitus is an historical disease which was first described in Egyptian manuscripts in year 1500 BC. At the same time, it has been described by the Indian physicians under the name of Madhumehaya. Diabetes mellitus is a status of chronic hyperglycemia and other metabolic derangements caused by inadequate action of insulin, either due to decreased production or increased resistance. Diabetes is classified into two major groups, type 1 and type 2. Type 1 is absolute insulin deficiency, often due to autoimmune destruction of beta cells, whereas your type 2 diabetes is relative insulin deficiency along with insulin resistance, and it often has a genetic predisposition greater than type 1. Maternal diabetes is another entity by itself, which includes gestational diabetes mellitus and pre-existing diabetes in pregnancy. Gestational diabetes is the one that you diagnose during the second or the third trimester of pregnancy, which is clearly not attributable to type 1 and type 2 diabetes. Whereas your pre-existing diabetes is the one that you diagnose during the first trimester of pregnancy. You have specific types of diabetes as well. Monogenic diabetic syndromes, which include neonatal diabetes and maturity onset of diabetes of the young or MODY. And also, you have diseases involving exocrine functions of the pancreas, like cystic fibrosis and chronic pancreatitis, which can cause diabetes mellitus. And also, you have drug-induced diabetes, which may be due to the steroids or maybe due to HIV/AIDS treatment. Diabetes mellitus is a common disorder having a global prevalence of 1 in 11 adults. Coming to Sri Lanka, it has a prevalence of 1 in 12 adults. Diabetes has a very clear-cut diagnostic criteria. If the fasting plasma glucose is equal or above 126, that is diabetic. If the 75 gram OGTT second hour value is equal or about 200, that is also diabetes mellitus. If the random plasma glucose is equal or above 200 milligrams per deciliter in the presence of classical symptoms of hyperglycemia, or if the patient is in a hyperglycemic crisis, that is also diagnosed as diabetes mellitus. HbA1c is also a diagnostic criterion at a cutoff point equal or about 6.5%. Whatever the glucose assay you perform, whether it is fasting, random, or GTT, a glucometer value is not acceptable. So your reading should always be a laboratory assay. Diagnosis of diabetes mellitus should always be confirmed by repeating the same test or using an alternative test, except in case of a hyperglycemic crisis or in the presence of classical symptoms of hyperglycemia. If the two results are discordant from two different tests, you have to repeat them and confirm. I mentioned about fasting plasma glucose, which need a fast of 8 to 12 hours, and you obtain your blood into a tube that containing fluoride and citrate. If the fasting plasma glucose level is equal or less than 110, it is non-diabetic. If the values are between 111 and 125, it is pre-diabetic. And if the value is equal or above 126, that is diabetic. I mentioned about pre-diabetic, and let's talk about pre-diabetes. If the fasting plasma glucose level is between 111 to 125, or if the OGTT, oral glucose tolerance test, second hour value is between 141 to 199, or if the HbA1c level is between 5.6 to 6.4%, you can diagnose pre-diabetes, which carries a risk of diabetes. But unlike over diabetes mellitus, your pre-diabetes can be reverted to normal. That is why it is important to pick up the patient with pre-diabetes and manage the patient properly so that he or she will not move into overt diabetes mellitus. I mentioned about OGTT. When I go to do an OGTT, if the fasting plasma glucose level is in the range of pre-diabetes, if the fasting plasma glucose level is non-diabetic, but still you have a clinical suspicion of diabetes. And of course, OGTT is the main tool in screening for maternal diabetes. For an OGTT, you have to put the patient on an unrestricted carbohydrate diet and physical activities for 3 days, and need a 8 to 12 hours fast. And you better avoid all the possible medications on the day of the test. And smoking should be stopped during the test. And your OGTT should best be avoided in hospitalized patients. 75 grams of glucose dissolved in 300 milliliters of water is given over 5 minutes, and the dose has to be adjusted in children according to their body weight. Your oral glucose tolerance test has two values, a fasting value and a 2-hour value. The fasting value in the OGTT is interpreted just like any other fasting plasma glucose. Whereas your second hour value, if equal or less than 140, is non-diabetic. If the value is equal or above 200, that is diabetes. And if it is ranging between 141 to 191, that is impaired glucose tolerance. Screening for diabetes mellitus is important because you picked up the patient before they developed complications of the disease. It is recommended to screen all individuals with at least one major risk factor, and fasting plasma glucose is the recommended test, and random plasma glucose is the alternative. If plasma glucose, which is the laboratory analyzed glucose, is not available, then you can go ahead with the capillary blood glucose, that is glucometer assay. So your screening glucometer assay is recommended, but for the diagnosis, glucometer assay is not recommended. I talk about major risk factors for diabetes, which include age equal or above 40, overweightedness with the body mass index equal or about 23 kilograms per meter square, family history of diabetes in parents or siblings, and habitual physical inactivity, hypertension, low HDL, and increased triglyceride, history of vascular disorders, history of gestational diabetes or having a large baby, diagnosed cases of polycystic ovarian diseases, and the presence of acanthosis nigricans. You consider the patient is a major risk for diabetes, and that patient should be screened for diabetes mellitus. Once the diagnosis is confirmed, You have to investigate the patient with the fasting lipid profile. Serum creatinine with an EGFR is indicated at the first diagnosis. Urine albumin creatinine ratio, thyroid function test in case of type 1 diabetes and in the presence of dyslipidemia. HbA1c should be done at the first diagnosis. So having diagnosed a diabetic patient, you have to follow the patient up for life with monthly fasting plasma glucose assays. HbA1c should be done once in 3 months until you obtain the optimal glycemic control. Thereafter, you can do it in every 6 months. Urine microalbumin creatinine ratio should be done annually. Lipid profile is recommended annually. I mentioned about the glycemic control. A good glycemic control is indicated by a HbA1c level less than 7% and a fasting plasma glucose level between 80 to 130 milligrams. Your HbA1c is an indicator of long-standing diabetic control over last 121 days, whereas your fasting plasma glucose indicates a short-term glycemic control. Postprandial rise of glucose is also important. So you have to assess the patient with the 2-hour ppbs. If the value is less than 180, you are happy. And this 2 hours in your ppbs is calculated from the first bolus of your food. If the patient is having an acute illness, and if the fasting plasma glucose is above 140, treatment is indicated for hospitalized patients. And if your patient is having a critical illness, you have to maintain his plasma glucose level at fasting level between 140 and 180, preferably the lower limit. I told you that HbA1c, the target level should be 7%. However, in young patients with newly onset of diabetes mellitus, in well-motivated patients in the absence of comorbidities, you can have a very tight glycemic control at a HbA1c level as low as 6.5. On the other hand, in all people with many comorbidities, a tight glycemic control is dangerous, and you might have a target HbA1c as high as 8%. Elective surgeries should be postponed whenever possible until you achieve a good glycemic control. If the fasting plasma glucose is above 180 with the HbA1c equal or above 9%, you better postpone your elective surgery and achieve your glycemic control properly before the surgery. After your surgery, fasting plasma glucose level should be maintained in between 80 to 180 during the peri and post-operative period. Right, those are my references. Thank you very much. If you have any questions, I will answer to the best of my knowledge.
Participants, if you have any questions from our speaker, you may ask now. We can spare a few minutes for any queries that you have.
Sir, can we take HbA1c7 as diagnostic in acute ill patient?
It's not diagnostic. Diagnostic set point is not 7 point. The glycemic control should be maintained around 7%. Right? In acute illnesses, of course, you can't go by HbA1c because that indicates a long-standing glycemic control. Okay?
Excuse me, sir.
I'm Kisali here.
Yes.
Tushar, can you just tell what are the associated diabetes associated things that we should measure, the complications, what are the tests that we should do to assess the patient's complications of diabetes?
Okay, good question. Right. So actually I mentioned that during the follow-up, you have to do a lipid profile and you have to assess the urine microalbumin to creatinine ratio in question of your diabetic nephropathy. Diabetic patients are more liable to develop lipid disorders, so lipid analysis at least annually is important. Right, then fatty liver is a possible complication. So if you have a clinical suspicion of a fatty liver, you might do a ALT, but it is not routinely recommended test. Right. Any other questions?
Yes, sir. Excuse me, sir. Can you say about something? I mean, the diagnostic cutoff values of GDM, sir, gestational diabetes.
Yeah, gestational diabetes cutoff values are different. Fasting value 92 or less is non-diabetic. So if it is above 92, that is gestational diabetes. If you see it during the second and third trimester of pregnancy. If you do a OGTT, which is better than the fasting plasma glucose, your OGTT value should be below 152 milligrams per deciliter. Those are the cutoff values. Some people do the 1 hour value also. If you go by the 1 hour value, that is 180. That is the cutoff point. Many VOGs in Sri Lanka, they don't recommend fasting. So they go by the OGTT, right? So OGTT 2 hour value is 152, the cutoff point.
Thank you, sir.
Tushar, Kisali again, can
Yes.
you just tell, because I think we are not included the lipid profiles in our, I really don't know whether someone will discuss, can you just tell the lipid profile, sample taking, what are the patient preparation and all the, something about lipid profiles, just how many hours and why we need the such a long fasting and all?
Right. We generally advise the patients to fast about 12 hours, but the College of Physicians of Sri Lanka, their guideline says that a 9-hour fast is adequate, right? So if the patient can fast for 12 hours, you better go for 12 hours, but even a 9-hour fast is acceptable, right? So why do we keep the patient fasting? Because your fast affect your diet affect your triglyceride level, and your triglyceride level is used to calculate the LDL level. So most of our labs do not measure LDL directly. So when you do the calculation, it utilizes the triglyceride value. So if the triglyceride value is affected by the diet, you get a falsely low LDL value. For this reason, you have to clear the postprandial triglyceridemia. So we recommend the patients to fast. And the recommended LDL level for diabetic is less than 100 milligrams per deciliter, triglycerides LDL level, and preferably it should be less than 70.
Thank you, sir. Do we have any more questions from the audience? Okay, so thank you very much for that informative and interactive lecture, sir. I'm sure our participants gained a thorough understanding on the role played by the laboratory in managing patients with diabetes mellitus. I also take this opportunity to warmly welcome Dr. Sudat Dharmaratne, Deputy Director General of of Laboratory Services, to the second day of our workshop. We are delighted and honored by your presence, sir. Okay, moving on to the next topic. As laboratorians, we all know that managing laboratory errors is a very important aspect in the laboratory practice. I warmly invite Dr. Manjula Disanayake, past president of CCPSL and consultant chemical pathologist, teaching hospital Karapitiya, to deliver his lecture on laboratory errors. Over to you, sir.
Thank you, Dara. Can you hear me? Okay.
Yes, sir, we can hear you and see you clearly.
Okay. I would like to thank College of Chemical Pathologists, the President, Dr. Kisal Hirimuthu Goda, and the Council for organizing this timely workshop, and also inviting me to do a talk in this workshop. Actually, the original topic was on the errors, the laboratory errors. I discussed with the president, and I just changed the topic a bit, because I think for the MOs, I think they should know about the errors as well. But I think they have many problems in the interpretation of simple day-to-day test. Therefore, I thought of okay, therefore I thought of doing some pitfalls in the interpretation of the medical laboratory test. I just want to tell something about the laboratory errors. Actually, when you say laboratory errors, that directly says all the errors happens in the laboratory. Earlier, the errors related to the lab test, earlier, some decades ago, and those errors were referred as analytical errors. But it is not the case. Now, later on, we start off talking laboratory errors. That is also give the impression that all the errors happens in the laboratory. But it is also not the case. Actually, most of the errors are happening outside the laboratory. As you know, I think sometimes you may have some lectures earlier regarding the laboratory testing cycle. Testing is a cyclical process. Actually, it starts in the brain of the doctor, and the doctor is the one who writes the test, and it starts in the brain of the doctor. Then these samples are taken by the nurses or the phlebotomists, then transported, and in the laboratory test are being tested. Then those samples are analyzed, and the reports are issued to the doctor later on. And then the doctor look at the report and interpret. right? Sometimes the interpretation may go wrong. Not only the interpretation, the request. Doctor may request the wrong test, or sometimes the requester's handwriting may be illegible. In that case, the laboratory will interpret the test in a different way. Sometimes the doctor may have written the ALT, but the laboratory people may read it as ALP, something like that. Sometimes the necessary details like patient's age, gender, history, and those things are not supplied to the laboratory. In that case, again, the erroneous test results can be released, and the doctor will interpret it erroneously, and patient management is affected. That is the issue. Therefore, I think as doctors, you have to understand you are also playing a major role in generation of accurate test results in the form of test ordering and in the form of interpretation and managing the patients. Therefore, later and nowadays, we call all these errors as testing related diagnostic errors. Now, generally nowadays, the analytical errors or the laboratory errors, those topics are very narrow kind of topics, and in broad aspect, we call all the errors happening related to the testing as testing related diagnostic errors. All right, actually today I'm going to talk on the interpretation issues, and we quickly move to that. And as I mentioned earlier, testing is a cycle. This cycle consists of 3 phases: pre-analytical, analytical, and post-analytical. All these phases even the analytical, that is in the analyzer, issues also can cause erroneous test results. Generally, I would say there are interpretation issues, then endogenous kind of interferences because of the hemolysis, bilirubinemia, lipemia, paraproteinemia, autoantibodies, etc. Then there are exogenous differences as well, interferences as well, drugs, and so many other factors. Actually, from this point onwards, I'm going to do the lecture in the form of case presentation, right? Now, the first case, just carefully read the case. And this is case number 1. The nurse recorded urine ward test results on a pregnant lady, right? That is happening in maternity ward all the time. They do the urine heat test, right? And they do the Benedict test, and they record the results. I have seen so many times on the BHT, they have recorded the results as mentioned here, albumin and urine sugar. That is how the nurses record the results. They do the heat test and record if there is any coagulation or any, that what happens, the proteins, if it is present, it is coagulated, and you can see at the top of the tube, right? Then you record depending on the thickness or the, if it is more, then you will say it is 1 plus 2 plus 3 plus. There's no coagulation, you would say nil. Or if it is very light, then you may say trace, something like that. Now, urine sugar, they record as urine sugar. They do the Benedict test. Green is there is something there. Right now, my question is, now here, suppose the same urine sample was sent to a private laboratory for a UFR. Patient in the morning give 2 samples, 1 sample for the ward test, and the doctor wanted to do a urine sample outside laboratory as well. And the outside report, it says urine protein nil, and urine glucose, urine protein nil, urine glucose I can't see the bottom. Anyway, urine I think urine glucose nil, right? Right. Now, can this happen? Now, what is the reason for that? Now, what test say albumin 1 plus urine sugar green, and the outside lab, no glucose, no protein. Now, you have to understand this. Now, in the ward, we do a heat test that is for protein, right? Albumin is one of the proteins. Therefore, you just very clearly understand albumin is a different test. Protein is a different test. Now, when you do the heat test, you look for the proteins, not specifically for albumin. Therefore, you can't say if the heat test is positive, you can't say albumin positive. That is wrong. You have to say protein plus. That is the correct recording of the results. Protein plus, not albumin. On the other hand, you can't say urine sugar. Right? Again, by the Benedict test, you are looking for the reducing substances. If that lady has taken a high dose of ascorbic acid, that is vitamin C, it can give rise to a positive Benedict test, maybe green or something like that. Then that doesn't mean that patient is having glucose, right? Therefore, you have to very clearly understand the meaning of the test. The albumin, that is wrong. You have to say protein, not urine sugar. Actually, it has to be urine reducing substances. Urine reducing substances green. Now, outside, that sample has been usually done by a urine strip test. In the urine strip, right, it specifically look for the glucose, not for the reducing substances, not for the fructose, not for the galactose, not for anything, only for the glucose. Then they specifically say whether glucose is there or not. Therefore, in this case, glucose negative, that means this patient is not having glycosuria. Urine sugar green because of some other reason, maybe ascorbic acid or maybe antibiotics like cefalexin or something like that. It is not due to glycosuria. Then here urine protein nil. Urine protein in the strip also, it is checked for the urine protein, not for the albumin. But by the strip method, it is negative. Now, urine strip is very specific for albumin, sorry, protein. In that case, now how can happen that albumin, that protein plus on the ward, in the ward? If the patient had some mucus in the urine, or if the patient had some red cells or white cells or something in the urine, when you heat it, it can give a positive reaction, right? It doesn't mean that patient is having proteinuria, right? You have to understand the difference. I think you have an idea about that. Then moving forward on a different sample, say same patient, for urine microalbumin test was done. Sample was sent to a lab for urine microalbumin. Actually, we say urine microalbumin. Now, correct terminology is urine albumin. Nowadays, we don't use the term called microalbumin. It is urine albumin, right? Now, there's another test for the urine protein that is called sulfur salicylic acid test. Most of the laboratories, this test is being done. Sulfur salicylic acid, that is acid. When acid is mixed with urine, what happened? Urine proteins are denatured and you can see as a precipitate, right? That same principle happens here. That patient's sulfur salicylic test is done, it is 2 plus, and strip test also 2 plus. Say different patient, right? Now, urine albumin report comes as negative. Negative means less than 30 milligrams per gram creatinine. No microalbumin, no urine albumin. How this can happen? As you know, albumin is one part of protein, right? There are many proteins other than albumin. For example, globulins, say immunoglobulins, say paraproteins, right? There are so many other things, even mucus or so many other things, right? Are proteins other than albumin, right? That kind of proteins can give a positive sulfur salicylic acid test, right? But when you do the albumin, it is nil because the patient is not passing albumin. That is why I told albumin. Then the albumin is measured very specifically. That test is specific for albumin. not for all proteins, right? Now this can happen. It is because some people can pass proteins other than albumin. In that case, sulfur salicylic acid test or the strip test may be positive. Urine albumin test may be negative, right? Regarding the urine albumin interpretation, I just want to tell you, actually, you have to do the urine albumin test not only once, right? Ideally, you have to do 3 tests, preferably within 2 months. 2 out of 3, if it is positive, then only you can say urine albumin positive. It is because urine albumin is positive because of other reasons, not due to renal problems, other reasons like hypothermia, that is, hypopyrexia, that is fever, then severe exertion, fever, severe exertion in females during the menstruation, those kind of situations, you can have urine albumin positivity. That doesn't mean this patient is having a microalbuminuria or the renal problems. That is why you need to do at least 3 samples, consecutive 3 samples, preferably within 2 months, right? 2 out of 3 positive, that means that patient is having microalbuminuria, right? Please remember that as well. Now, case number 2, a specimen from a newborn, day 1, was sent to the laboratory for serum electrolytes. I think when you have worked in pediatric wards, you have enough experiences. The laboratory has issued the following report. Serum sodium 142, as per the reference ranges, it is normal. Serum potassium 6 moles per liter, as per the reference ranges, it is high. Now, what is your interpretation? Right? What is your interpretation? Now, some may interpret this as a high result, but it is not the case. It is not, because you have to know, in neonates, the reference ranges for the serum potassium is at a bit higher level, not this range, not 3.5 to 5.1. That is for the normal adults, right? Normal adults mean even children, same values, but for the neonates, up to 14 days of their life, neonates, they are having bit higher reference ranges. I think up to 6.5 may be normal, right? In a neonate, especially day 1 neonate, up to 6.5 may be normal. Therefore, serum potassium 6 is not a value that you should panic. It can happen, right? It is normal, right? That is the interpretation. That is why we always ask the doctors to send the history to the laboratory, not only the history, age of the patient, gender, because most of the reference ranges are gender and age specific. If the laboratory doesn't know about the gender and age, they won't be able to give the relevant reference range, because some laboratories in Sri Lanka are computerized. In the computerized system, they select the specific reference range when you feed the gender and the age of the patient to the system. Then we don't give all the reference ranges, right? We specifically select the particular reference range and that print on the report, right? Now, in this case, sometimes if those data are not supplied, you may not get the correct reference range, right? Case number 3, the house officer has requested a urine protein on a spot urine sample. The laboratory has issued a report with the value of 40 milligram per deciliter. House officer calls to the lab and asks the reference range for the serum urine protein. Now, what do you say? Now, this happens commonly, right? Not only in the government sector, even in private sector, so many cases are there, right? Some doctors request just urine protein. Then laboratory, they do what they request. But actually, urine protein on a spot sample, you can't interpret. Because, as you know, urine is all the time, the consistency is changing. Sometimes it is diluted, sometimes concentrated, right? When it is diluted, you will have a low urine protein value. When it is concentrated, it may be several fold high. Therefore, you can't interpret not only urine protein, urine calcium, urine albumin, urine uric acid. Most of the urine test you can't interpret alone. You always have to do urine creatinine as well. Urine creatinine is the hallmark of urine, right? That the creatinine also will show the same dilution and the concentration as that for the protein or the calcium. Therefore, when you express urine protein as a ratio to creatinine, protein to creatinine ratio, that ratio will not change. Then that for that ratio, you can have reference ranges. Therefore, in this case, requesting just urine protein is not acceptable. That is wrong test. You have to request protein to creatinine ratio, right? In the laboratory, as laboratory doctors, if somebody has requested like that, then you should advise the MLTs, if they are having queries, to do creatinine as well and give the results as a protein to creatinine ratio. For the protein to creatinine ratio, there are reference ranges, right? Like albumin to creatinine ratio. Some people I have seen just ask urine albumin, urine microalbumin, something like that. But you have to do the albumin to creatinine ratio or the protein to creatinine ratio, calcium to creatinine ratio, right? This is this is example for a report issued by our lab. You can see protein is done and creatinine is done, and finally we give the protein to creatinine ratio. For that, we have reference ranges. Case number 4. The pediatrician has requested serum creatinine and EGFR on a 7-year-old girl. This laboratory has issued a report with the EGFR value of 100 milliliter per minute per 1.73 square meter. Can this result be accepted? Now, can issue a report like this? I think this is a wrong report. Why wrong? Number one is you can calculate the EGFR in a child. Pediatric EGFR can be calculated, but that is a different formula that is called, I think, Schwartz formula, bedside Schwartz formula, and Schwartz formula is there. But for this formula calculation, you need the length of the child, length and gender and length of the child. If this information was not requested by the laboratory, that means they have done a wrong calculation, right? That is why this cannot be accepted. This is a different formula. You know the EGFR. EGFR can be in adults calculated by commonly used formula are there. One is called CKD-EPI. The other one is MDRD formula. For those formulas, you don't need the length or the height. But for the pediatric formulas, you need the length of the child, right? If a laboratory has not asked the length, that means this result is wrong, right? Case number 5. A 40-year-old male diabetic was admitted to a surgical ward with a right foot ulcer. Lab investigations on admission, you can see 40-year-old diabetic patient, right foot ulcer. Investigations on admission, random venous plasma glucose 490 milligrams per deciliter, serum creatinine 178 milligram micromoles per liter, blood urea 60 milligrams per deciliter. I think you can see all the results are high. Blood glucose result is markedly high. How do you interpret renal function test results in this patient? Now, this is also commonly happening. Now, in the medical world, you have a lot of diabetic patients. They do renal functions on these patients, and they may get results like that. Now, can you say this patient is having a renal failure? Serum creatinine high, urea high, Is it renal failure? I don't think. You can't say. Why? Most of the serum creatinine is done by a method called Jaffe reaction in the analyzer, in the laboratory. There's a different kind of assay principle, Jaffe reaction. This Jaffe reaction is interfered by glucose, not only glucose, ketone bodies, high proteins, etc., even antibiotics, right? It is positively interfered. That is positive interference. Positive interference means when the glucose is high, you will get elevated, erroneously elevated, falsely elevated serum creatinine, right? Blood urea also marginally high. In a diabetic patient with that much of glucose, tend to be dehydrated, right? In dehydration, you get elevated urea as well. Therefore, I will not hurry to label this patient as a renal failure patient. I will check the renal functions on this patient after the patient is settled in the form of glycemia, and clinically patient is stable. You have to repeat the renal functions and see what are the creatinine and urea now, right? Most of the time it may be normal, right? Therefore, elevated serum creatinine and blood urea in this case doesn't confirm the diagnosis of renal failure, right? All right. Number 6, case number 6, the same patient had following electrolyte results on admission. Serum sodium 129, serum potassium 5.6. There were no symptoms of hyponatremia or hyperkalemia. How do you interpret these results? Sodium low, potassium high. Right. Now, there are several reasons. There is something called dilutional hyponatremia. What is dilutional hyponatremia? When somebody is having very high glucose, right? Like this patient, like in this patient, there will be a water influx to the cells. That is how you get the the water influx to the extracellular fluid compartment from the cells. There will be cellular dehydration. With this water coming to the extracellular compartment, sodium get diluted. That is called dilutional hyponatremia. That is a very common incident, right? On the other hand, with acidosis, right, and the other factors, losing the electrolytes in urine, losing electrolytes in the urine also may contribute to some extent. On the other hand, with acidosis, you have high hydrogen ion outside the cells, right? Then cells take this hydrogen ion in, and in exchange of potassium out. Therefore, potassium going out of the cell and hydrogen move into the cells. There's a that is called a potassium shift. That will result in elevation of the potassium, right? That is how you get elevated potassium and hyponatremia, right? There are many other factors for the change of the electrolytes. Anyhow, you have to understand this fact. When the patient is stable, everything may be normal, right? Now, what should be the laboratory's role in reporting electrolyte results in a patient like this? Actually, there is something called corrected sodium, like corrected calcium, corrected sodium. Sodium correction for hyperglycemia, that is corrected sodium. What does it say? For every 100 milligram per deciliter increase of plasma glucose, above 100, we get the 100 as the baseline. Above 100, for every 100 increase, 2.5 millimoles per liter of potassium will be reduced. Therefore, you have to add it. Now, in this case, this patient is having 490, that is 390 milligram per deciliter is sodium per glucose. is above 100, then you have to multiply 2.5 by 3.9. Then you have to add that value to the 129. The patient had 129. Then the calculated value would be 136. Now corrected sodium is 136. That is normal. Therefore, the ward people should act on not on the measured sodium, they should act on the calculated sodium. I don't think any laboratory nowadays giving the calculated sodium, but this is very important, right? I think you have to understand this is a very important factor. You can't act on measured sodium in a case like this. You have to act on the calculated sodium, right? This is how you do the calculation. Case number 7, same diabetic was positive for urine ketone bodies on admission. Now, urine glucose 490, and that is natural. That patient was checked for the urine ketone bodies, and it was 1+ on admission. Right. Now, patient was started on treatment. After treatment with insulin, his glucose level improved, and it reduced to 150 milligrams per deciliter. Now, house officer again had sent a sample for urine ketone bodies to the laboratory. Right. Then laboratory had issued a urine ketone bodies report of 3+ this time. Now, we have seen some people argue with the laboratory saying that you have issued a wrong report. How can this happen? On admission 1+ with high glucose, now glucose is normal, almost normal. Now you give us a report of 3+, right? We cannot accept your report. Something like that can happen. That is happening. That has happened, right? Can this happen? Actually, that is what happening, right? That is the reality. How? As you know, in diabetes, uncontrolled diabetes, diabetic ketoacidosis, the major ketone body would be, I think, beta hydroxybutyric acid, right? Beta hydroxybutyric acid. The ketone body test, we test not for the beta hydroxybutyric acid, we test for the acetoacetic acid or acetone, right? The test check the acetone. Now, at the peak of the diabetes, the patient is having more beta hydroxybutyric acid and less or very minimum acetoacetic acid. Therefore, that is why on admission, this patient had a ketone bodies of 1+. When patient is treated, this beta hydroxybutyric acid is converted to acetoacetic acid. Now, more and more acetoacetic acid in blood with the treatment. Therefore, when you do the ketone bodies test, it becomes 3+ or 4+. Now, the ketone bodies are more when the patient is improving, right? Please just read and how ketone bodies are produced and the treatment, how the treatment will change the ketone bodies in the blood, right? That is what actually happening, right? I think you got the point. Case number 8. Following results are available on a 60-year-old male patient with jaundice. Total bilirubin 14 milligram per deciliter. That is very high. Serum creatinine 0.4. It's very low. Blood urea 48. It is a bit high. How do you interpret renal function test in this patient? Now, creatinine is low. 60-year-old patient, right? Now, here, the clue for the low creatinine is there. I told that earlier, the serum creatinine is measured by a method called Jaffe reaction on most of the laboratories. This Jaffe reaction is having positive interferences as well as negative interferences. Positive interferences, as I mentioned earlier, ketone bodies, glucose, proteins, high ketone bodies will give rise to erroneously elevated creatinine. But high bilirubin is a negative interferent. Very high bilirubin levels will result in falsely low creatinine. Now here the creatinine is low. It is because of high bilirubin. You have to understand this fact, right? Okay. Case number 9. A laboratory has issued a report as follows. Serum creatinine 10 micromoles per liter. That is very, very low. AST less than 2. That is almost 0. ALT less than 2. That is also almost 0. In the report, they have mentioned that sample is milky in color. How do you interpret these results? Now, all the clues are here. Now, sample is milky in color. What does it mean? Samples are milky in color or very milk, like milk. When you observe the sample, when a patient is having very high triglycerides, usually triglycerides more than 1000 milligrams per deciliter, right? Sample is almost like a milk, white color, right? Samples like this will give rise to lot of problems, right? Very difficult to analyze most of the test because this lipemia, we call it lipemia interfere with many test results. Now this is the example. Even lot of biochemistry tests will be negatively interfered. Most of the test results will be very low because of lipemia, right? That is what has happened here. Serum creatinine is low because of the lipemic interference. AST and ALT are low because of the interference. Now, you can either do a kind of that is what we generally do. We do a dilution and do the test, right? Or otherwise, we may ask the patient to keep fasting, and after a fast, sometimes we may try to do the test, right? Keep in mind, with high lipemia can cause erroneous test results. When you interpret, you have to carefully interpret these results, keeping that fact in mind. Case number 10. A 50-year-old female with known diagnosis of rheumatoid arthritis presented to the medical ward with abdominal pain, and basic laboratory investigations were normal except alpha amylase. Alpha amylase means amylase. Amylase was 200 units per liter. The reference range is less than 100. Now, only abnormality was amylase. Because of the abdominal pain, amylase you have to do, right? Specimen was checked for lipase. The amylase and lipase are elevated in pancreatitis. Now, specimen was checked for the lipase. It was normal. Now, how do you explain this? Is it a laboratory error? Anyway, during the follow-up, she had the same elevated levels of amylase. Again, amylase was around 200. Now, that means this patient is having consistently elevated, isolated elevation of amylase. How do you interpret this elevation of amylase? Now, that is basically you have to exclude almost all possible causes. Now, in this patient, almost all causes for the abdominal pain and elevated amylase was done, rule out. Only the amylase was standing here alone, and for long period, all the time amylase was elevated. This can happen. That is called macroamylasemia. Macroamylasemia. That means sometimes somebody who are having abnormally high antibodies or autoantibodies, these antibodies can bind to amylase, and renal clearance will be interfered. So generally, amylase cleared by the kidneys, right? Then levels become normal, right? Somebody get acute pancreatitis, amylase going up, and when the condition subsides, the amylase also going down. The additional amylase, excess amylase are removed from the kidney. When it binds with antibodies, that renal clearance will not happen. Therefore, these amylase getting accumulated in blood. That is why you get always elevated amylase. This is called macroamylasemia. That is a kind of a You know that's not a pathological condition. Pathological condition means that patient may not have any disease, but amylase is high. That can happen for many other analytes like, say, CPK. Some people may have macro CPK. They are having all the time elevated CPK, right? Then prolactin. Some people are having always elevated prolactin. That is called macroprolactin, right? There are many analytes. Macro AST, even AST also, only AST is elevated, right? There are some analytes which are having this kind of macro complexes, which are not cleared by the kidneys. Therefore, keep that fact in mind, right? Always elevation of something doesn't mean a disease, and this is totally a benign condition, right? Case number 11. 50 years old female was diagnosed. Okay, time is up. Give me 3-4 minutes. A 50-year-old female was diagnosed to have hypothyroidism 3 weeks ago. Her thyroid function at the time of diagnosis were as follows: TSH more than 100, free T4 5.4. TSH was high, free T4 was low, that is primary hypothyroidism. She was started on thyroxine, follow-up TSH result done at the end of 3rd week, TSH 40. Now, what is your interpretation? This is also commonly done. Now, what is the issue? This is TSH is not the test to do for the follow-up, right? Because TSH will take time to come to normal levels, though the patient is on the correct dose of thyroxine. It will not come all of a sudden to the normal level. It will take sometimes more than 2-3 months. Therefore, beyond 2-3 months, that is at the very first few weeks, you should monitor the patient using T4, only T4. You should not do TSH. Right here, TSH is 40, right? That doesn't mean this patient is not responding to the treatment. You do the T4, and if it is normal, then you can assume that the patient is on correct dose of thyroxine. Therefore, in the first weeks or first few months of the treatment, you should monitor the patient with thyroxine, not with TSH, right? It's waste of money. Right, case number 12, a 40-year-old lady with severe vomiting and history of POA of 8 weeks. That is, she is having a POA and she is having severe vomiting. She is at 8 weeks. Investigation TSH 0.1, that is low. Free T4 high. It is give the picture of primary hyperthyroidism. And her HCG is inappropriately high. That is 563,000. That is very high for 8 weeks of gestation. Now, what is your interpretation? This patient is most likely is having a condition like HMOL, right? HMOL, very high HCG. HCG has an effect on the thyroid receptors, and because of that, more and more T4 can be produced, right? Creating a kind of a hyperthyroidism-like picture. Now, that is what has happened here. Right, case number 13. House officer finds 2 very recent urine. I can't read that slide. Right. Thyroid function test on a pregnant lady at. Sorry. House officer find 2 very recent urine HCG test by strip method done on this patient are negative. Sorry, this patient who has very high HCG, house officer has done a urine strip test for the HCG. That again, it's HCG strip test. That was negative. Could this possible? Is it an error? Or sometimes if you send a sample to the private lab or hospital lab, they may report it as negative. Patient is having several lakhs of HCG, right? That happens. How? In the strip, the detection method of the HCG is a kind of a immunoassay, right? That detection method is interfered when the urine is having very large number of HCG molecules, right? Then it will end up with a negative result. When you do the urine sample, when you do a dilution, Sometimes you may need a very high dilution, 1 in 50 or something. When you do the test on a diluted sample, now it becomes positive, right? It is a kind of a error related to the interference, right? Case number 14. Thyroid function test on a pregnant lady at 15 weeks of gestation were as follows: TSH normal and free T4 low. What is your interpretation of thyroid function studies? This is actually in pregnancy. Remember, there is something called condition called hypothyroxemia of pregnancy. Hypothyroxemia. It is a physiological phenomenon. It is considered normal. Some pregnant ladies are having low free T4 levels. Keep that in mind. It is not require. It doesn't require any treatment. Case number 15. One baby of non-identical twins born with features of liver failure and lactic acidosis. You can see TSH normal and free T4 was very high, free T3 very high, right? Very high T3 and T4, TSH normal. Thyroid function results of the mother and the other twin normal. Now, you have to, in this kind of cases, discordant results, you have to check what is going on. Now, sample was sent to a different lab, and different lab, the results were normal, right? On a different platforms. Different platforms mean analyzer to analyzer, the detection methods are different, right? Keep that in mind. Some analyzers are interfered by some things, and the same interference may not happen on the other analyzer, right? In that is how you check this interferences. And there is another way, heterophile antibody interference, that is antibodies in the body, and there are techniques to check that as well. That was done, and that is also normal. I mean, there were no heterophile antibodies. The results were normal on a different platform. The further questioning, the mother was given very high doses of biotin. Biotin, I think you know, it's a kind of a vitamin, and it is given for the especially acidemic conditions. In infants, it is given in very high doses. I think in beauty culture also, a lot of females are ingesting a lot of biotins nowadays, I think. And this biotin, the assay, our assay method is having a biotin-related antibodies to detect this thyroid hormone. This biotin, the biotin taken from outside, that is present in the blood sample. When you analyze that sample with biotin and the reagent is having biotin-related antibodies, that interfere, right? That is why you get very high thyroid hormone results for no reason. That is only an interference, right? That is the explanation. That kind of interferences are happening all the time, right? I think there are a lot to, when you discuss, there are many things to discuss in the interpretation and the, interferences, etc. But just keep in mind, you try to knowledge on the interpretation, especially regarding the interferences, etc. Then it will help your day-to-day practices, your private practice or whatever. Before blaming others, you just try to understand what is going on with yourself, right? One thing I want to say, nobody can say a result is wrong. I have seen some private sector laboratories, consultants, doctors, report a wrong report. You can't do like that. You have to say a report is wrong. You have to have very big knowledge, because sometimes result negative minus 10 or something, then you can say it is wrong. Otherwise, what you can say is this is clinically not compatible. That is why you say wrong. You say wrong something when it is clinically not compatible. You can say that. You can say this is clinically not compatible. Please help us by doing the repeat test or whatever. But you can't say just wrong report, right? Nobody can say. Because there are so many factors which will cause a wrong report, right? Without looking for all these factors, you just can't say wrong report. You can say this is clinically not compatible, right? Okay, thank you for listening. Sorry for taking extra time.
Thank you, for that excellent account on how to overcome pitfalls encountered during laboratory report interpretation based on case-based discussions. It was an excellent lecture. Since we are behind time a little today, we'll be moving on to the next lecture. The cardiac markers play an important role in managing patients presenting with acute coronary syndrome. To discuss about the cardiac markers, I warmly invite Dr. Saman Pedruheva, consultant chemical pathologist of Colombo South Teaching Hospital, Kalubovila. Over to you, sir.
Thank you, Dara. I hope you can hear me.
Yes, sir, we can hear you and clearly see you.
Yeah, I want to put this into the full screen.
Sir, please click on the slideshow and yes.
It's called, right, okay.
Okay.
Now, is it disturbing? Yeah. All right. Good morning, everybody. I'm going to talk on cardiac markers. So, first of all, I will discuss what biomarkers are, and then I will take most of my time on discussing about troponin 9, since it has appeared as the most important life-saving cardiac marker. But then very shortly, I'm going to discuss a little bit into the history of these biomarkers and how these biomarkers, what other biomarkers have been used in the past and now, and what new biomarkers are appearing in the market and on research level. So let me start by explaining what biomarker is. So it's a substance or molecule or gene with particular character by which a particular pathological process or physiological process or disease can be identified. So this must indicate something, and it should be measurable to be meaningful. Now I said gene. When you explain a gene, it doesn't sense like it's a measurable marker. But if you can express in, if you can give results in the gene expression level, then it become a measurable marker. But there are very straightforward biomarkers which can be measured, but at the same time there are markers which can be assessed in indirect way. However, both can be used for our purposes. So if you want to find a ideal biomarker, it has to be very specific. We will discuss some of these terms a little bit in detail later. But what is specific? That specific means it tells you only about the condition of interest, nothing more than that. So now, for example, we know in liver disease, going away from cardiac, in liver disease, ALT levels and AST levels are elevated. But is it elevated only in liver disease? It's not. So ALT, so therefore, is not a specific marker. But when it comes to cardiac markers, we are concerned about this specificity. So the ability of a particular test to detect that condition of interest uniquely. So it's so we can talk on the negativity of that, but this is the simple explanation. Sensitivity is is the ability of a test to catch a disease. How far or to what degree a test is capable of catching it, right? So a sensitive test should detect a problem even at a very initial or minor degree level. Positive predictive value is something related to the test result. Now, when you say positive, how far are you accurate? So these positive predictive values tell you something like that. So it's different to the sensitivity. Sensitivity is the ability to catch a disease, but the positive predictive value is the character or the feature of the test to be accurate when it says positive. Similarly, you have negative predictive values. So when it is negative, how far it is accurate. So these biomarkers should produce stable results, and ideally it should be accessible in non-invasive manners, right? So it should be stable in long-term storage, right? So the cardiac, now we move to the topic proper. We are going to talk about the cardiac biomarkers. So these are substances released by the heart or the cardiac muscles. Now you know this. You are very familiar. The coronary artery disease, fibropathy, plaque formation, and then how it occludes. The aneurysm can be formed, thrombus can be blocked there, and then the stenosis into a critical level. But how this is related to our biomarkers? Now, this slide this picture explains you the type of biomarkers and the usages, common usages of these. Some of these. Now, at the level of inflammation, for example, you can see C-reactive protein coming up, and then there's a marker called this CD40L. So this is a carbohydrate antigen, and then so it's also appears in inflammatory conditions, and then myeloperoxidase. So I'm just giving you some examples. These are some of these are not in routine use. We don't use them, but these still can be demonstrated at least at research level in these kind of conditions. And then when it comes to the ischemic level, ischemia or the less oxygen situation, unbound free fatty acids, and this ischemia modified albumin. So this is IMA, is the ischemia modified albumin. So that start to appear, and with the injury, these proteins and CKMB and myoglobin start to appear in blood, as well as in ventricular failure, BNPs or brain natriuretic factor. NT-proBNP is another form of the same analyte, also start to appear. Now, what is MI? So the definition of MI based on the ECG findings somewhere in 1990 and before. So it still appeers as a standard test, but the definitions have changed from time to time. With the introduction of this cardiac biomarker, the focus began from actually 2000, and then 2000 universal definition was introduced, and just to give you a sort of overview how these things appear, introduced, so certain biomarkers were used, but not in a very specific manner. So these kind of techniques have been used along with the analyte, and with these techniques, the sensitivity level were improved. Some of these techniques, initial techniques, were later abandoned with regard to those analytes, and more sensitive techniques were introduced later on for the same analyte. And after 1989, the troponin was introduced. However, this, as you know, the troponin is coming from muscles, so it is not only appearing in cardiac muscle; it appears in skeletal and other smooth muscles as well. So unless you have something specific to cardiac muscle, the use of troponin was not that popular. But however, the troponin was introduced somewhere in 1989, and then later improved to high sensitivity troponin level, particularly with regard to the cardiac isotype. So they have become the gold standard later on with the introduction of the fourth universal definition of myocardial infarction in 2018. And so this is how it was given as a summary. I will enlarge this part of this summary in the next slide. Oh, sorry. For some reason, I'm very sorry. For some reason, this slide doesn't appear. Anyway, so it's yeah, okay, you're there. So there are different types of myocardial infarction. So this troponin is important with regard to type 1, type 2, and to some extent in type 3. Now, the European Cardiac Society has given this kind of definition for type 1, type 2, and type 3. It says the elevation of cardiac troponin, either I or T, with above 99th centile. 99th centile I'll explain in a minute. So 99th centile is taken as upper reference limit. You will understand that very soon. And with one of the following features: symptoms of myocardial ischemia, new ischemic changes in ECG, pathological tube wave, and imaging evidences from ischemic etiologies. So this is with regard to echocardiography, and identification of coronary thrombus by angiography or in the autopsy. So with this definition, I wanted to tell you, just to get an idea onto the usage of this troponin I and troponin T, or cardiac troponins, and to highlight the importance of this particular test. Now you can see, as we explained earlier, the ideal biomarker should be very specific, should be very sensitive. Now, sensitivity, I told you, explain you how early this biomarker appear in blood level in detectable quantities. So as you can see, CK or CKMB. So the CKMB is this line, this orange line, appears in 3 to 12 hours. So troponin, with the improvement of troponin detection, actually now troponin can be detected even at at about 1 hour's time. So they appear generally within 1 to 3 hours. Myoglobin, again, an early marker, which is given in red here. Troponins are given in, troponins are given in blue and green lines. And then the LDH. LDH is the gray line, which is having very low rise. So if you have a higher rise, the chances of detection with our routine field methods, which we use in the laboratory, are very high. So our method is sensitive enough, the technically sound, then the chances of catching even at low levels become very high. So therefore, with the improvement of the technology, with new inventions, these troponin assays have been improved, and then that now has come to a level where even at a very low level of troponin, it would produce reportable results. So the users are becoming greater with the ability to catch these substances at early stages of this particular condition. Now, just to explain you what troponins are, as you can see, there are two types of filaments in any muscle, actin and myosin. So these thick and thin filaments, as you commonly know. So these thick filaments moves in relation to the thin filaments when the muscles are contracting. Now, for this contraction, there's a particular unit functioning. This one, this functioning, this unit, the relative movements of this unit matters in this relative movements in the thick and thin filaments, or actin and myosin filaments. So as you can see in this picture, this is tropomyosin and this is actin, and these tropomyosin and actin are bound together, and then the interaction with the myosin molecules through these subunits occur by these troponins. There are three types of troponins, C, I, and T. As you can see, C initiate the contraction action by binding to calcium. So the calcium binds to T, troponin C, and then the I binds the actin in the thin myofilaments to hold the tropomyosin complex, and then T binds to tropomyosin. So this the binding activity is done by I and T. Calcium binding and initiation of the contraction occurs with troponin C. So if you go into further details, this troponin is present. All three isotypes are present in cardiac muscles, skeletal muscles, and smooth muscles. But if you go into the molecular details, the finer details, you would see there are some changes between cardiac troponin and the troponin type present in cardiac muscles, and the troponin type mainly present in skeletal muscle. So the skeletal muscle troponin you can identify separately as skeletal muscle troponin I and troponin T, and the cardiac predominant troponin can be identified as cardiac troponin I and cardiac troponin T. but that doesn't mean the cardiac troponin is not present in skeletal muscle. Cardiac troponin is present to very, very small extent. The vice versa is also valid. Some skeletal muscle troponin is also present in cardiac, but it's in very, very small amount. So that gives you another indirect message, that is, if you see an elevation of cardiac troponin, so that means it's coming from the heart. But when it comes to some other analytes, particularly CK, it's not the case. You cannot make this differentiation. So that is one reason why this cardiac troponin assay is popular than any other cardiac biomarker with regard to the diagnosis of MI. Right. So this is another reason why this cardiac troponin is used. And if you compare with another analyte, CK-MB, we will discuss this creatinine kinase later. Creatinine kinase has 3 isoforms: CK-BB, CK-MM, and CK-MB. CK-BB coming from the brain, CK-MM particularly mainly coming from cardiac muscles, and CK-MB mainly coming from CK-MM mainly coming from skeletal muscles, CK-MB mainly coming from cardiac muscles. So, but if you take the amount per gram myocardial tissue or myocardium, the troponin present is about 13 to 15 times greater than the amount of CK-MB present. So therefore, it is no wonder when a damage occurs, more troponin is released, and so therefore, the detection, if you think about the detection, chances of detection, the troponin chances of detecting troponin is high compared to CK-MB. So is easier, in other words, compared to CK-MB. So that is one reason for improvements of this troponin assay, with these improvements, now we can detect even at very early stages, like within 1 hour's time. So another advantage in using the troponin is that it tells you about the size of the infarct. So the amount of troponin release, now as I explained you, it appears in certain concentrations in cardiac muscle, cardiac substances. So with the in proportionate to the level of damage, it appears in the blood. So I think I have explained this small. So this is the ability to detect even at a very low level. So if your assay sensitivity is high, that means the usability of that kind of assay is going to be more. And now you can see this shows you the concentrations of the different types of troponin assays. You know, in 1995. So the troponin curve appears like this. You know, in any coronary conditions, any cardiac damage, it increases in about 24 hours and then start to drop gradually. Then start to drop. But then the assay developments were quite different to this development. Now, in 1995, the cutoff values were something like this. You know, these cutoff values were decided on the basis of the levels distributed in a normal population. So in 1995, the ability of the method developed at that time were only able to detect 99 centile of the population at this particular concentration something like 1 nanogram per milliliter. But later on, these methods were improved, and by 2007, it was possible to measure something even below 0.1, between 0.01 and 0.1. Now, actually, things are even lower than 0.01. So now the assays can detect even levels somewhere there or even below. So those are called high sensitivity. That's why they are called high sensitivity troponin. You will understand this in the next slide. With the development of high sensitivity troponin, the distribution curves are like this. With the second generation, the 99 centile was somewhere there, and now these are the fourth generation troponins which we currently use. The 99 centile appears somewhere in about 0.01, 0.1416, something like that. So the levels have come down. That means the sensitivity of these detection methods have been improved, right? So the precision means precision is also one character which we look for when we are using an assay. Precision is the ability to produce same results when it is tested repeatedly. So in other words, if you test it repeatedly, that tells you the ability of detecting that in the same value, same level. So it is expressed as the CV percentage. So it tells you the repeatability or reproducibility. Characteristics of, with regard to these terms, the characteristic of high sensitivity troponin assay, cardiac troponin assays, have been explained, and that differentiate high sensitivity cardiac troponin assay from conventional troponin assay, which you need to know as laboratory persons or medical officers or medical practitioners who are using these laboratory results. You need to keep this in mind, this analytical sensitivity and analytical precision. So the CV should be less than 10% at the 99th centile in a high sensitivity troponin assay. And it should be capable of detecting at least 50% of the normal population at the level of lower detection limits. So the lower, in other words, the lower detection limits have come down in these troponin assays. Now this chart tells you the different types of brands. If you are working in a laboratory, you might be familiar with some of these commercial brands, branded analyzers. So this is Abbott Arctic. It has so this is the conventional assay. It has only 14% CV at the 99 centile. But when it comes to the high sensitivity assay, as you can see here, it has only 4%. So you can see the improvement. So you can see now these diagnostic instruments like Roche, Siemens, Orthoclinical Diagnostics are available in our laboratories. So these machines are used in some of our laboratories, and this tells you how precisely they measure. And this level tells you the cutoff values. So as you can see, the cutoff values have been changed and are different from one kind of assay method to another assay method, or one manufacturer to another manufacturer. This you need to keep in mind, because if you are comparing, if you want to check the difference between two values, you need to compare with the same analyzer, but not with different analyzers. Right. Again, the same one, same information is given here. And this tells you the lower detection limit, the lowest detection limit. I'm not going to explain you in detail, but the possible lowest limit. So it tells you, in other words, so the different brands have different levels, as you can see. So if the particular type, if the analyzer can go into very low level, that means the usability is again high. So you can start from very early stages. All right. So this, if you want to go into further reading, this particular article can be referred, and this article gives you 10 recommendations. I start giving. Considering the time available, I start with the recommendation 3. It has to be so it has to be age specific, and it has to be age, if possible, sex. It has to be sex specific, but the age specificity is not really recommended at this moment. And the reporting unit should be in nanograms per liter, and then I will move fast. The 5th recommendation, the lowest detection limit should actually measure at least 50% of the healthy men and women, 50% of the population. Laboratories should communicate with clinicians on the pre-analytical and analytical problems, because these tests, the troponin test, is not standard, not a standardized test. There are certain problems, but the world bodies governing these analytical procedures, and the researchers are trying to standardize these methods, methods between different manufacturers, but still the attempts have not been very successful. So there are differences, as I mentioned earlier. There are differences between different analyzers. So therefore, clinicians must be informed on these, and they must be aware when things are measured, and the pre-analytical conditions. So many pre-analytical conditions can give rise to error results, and these are some of the examples. So hemolysis should be stopped. Other interfering substances, particularly drugs, should be considered when you are assaying these substances. All right, I'm moving fast. So I explained this. So this the 9th recommendation, this cardiac troponin should be reported within 60 minutes or less. You know why? If you want to have some success in the intervention, whatever the intervention procedure in a myocardial infarction, it has to be performed within 6 hours of the onset. So if you report it very late, there is no point in reporting this cardiac troponin. So at least every attempt must be made to report this, give these results within 60 minutes. But actually, if things can be, if you use heparinized blood, you can issue results even within half an hour if you have a very efficient transportation and analytical systems. Actually, analytical systems have been improved to complete a test within about 15 minutes to 20 minutes. And if we can improve the transportation, actually these results can be given within half an hour or maximum of about 40 minutes. So every attempt must be made to issue these reports as early as possible to be useful for the clinicians to make decisions on interventions. The 10th recommendation, as I have explained you, we should educate clinicians. Now, this reference change value, I'm not going into detail. The reference change value, there's a term called reference change value, which has been defined with regard to the biological and analytical variation. Biological variation is the variation when we see between of the same analyte between people and between the day, throughout the day. If you measure certain analytes, certain substances in the morning, even in the same patient, if you measure when you measure in the evening, it is different. That is because of the biological variation. You know, the impact of your lifestyle, impact of your diet, the day-to-day activities, hormones, and so on. So with these, the substance the same even within the same person, the concentration of the substance can be changed. So it is called intra individual variation. And if you take similar people, identical people, the concentration may be quite different. So that is the variation in between people. That's why we have when we explain a reference value, reference interval, we give a range. We don't give a particular fixed value. So this range tell you normal people who are having variation in between them. So it's called inter-individual variation. So this both together called the biological variation. The analytical variation is the variation you observe in the machine. When you do it repeatedly, how you know your analytical systems might be very efficient, very sophisticated, and using state-of-the-art technology, but still, if you check it, you can't produce the same results all the time. There is always even a very slight variation. So this is called analytical variation. And with this analytical variation and biological variation, you define a particular value for each analyte. So this value is the reference change value. And if a change in troponin, when you assay serially, if a change in troponin or delta difference, the delta value is more than this RCV or reference change value, that has to be taken as a significant change. So that is the importance of defining this reference change value. So the reference change value is generally considered as the 50% of the value given at 99 center. So if a difference occur more than that, then that change is significant. So if you don't have any algorithms, but now there are number of algorithms which explain how to take decisions, how to make decisions with regard to this troponin and other clinical features, along with considering them together. So the changes in troponin has been explained even within about 1 hour's time, 2 hours time, 3 hours time. But now 1 hour protocols becoming more popular, particularly with non-ST elevated myocardial infarction. So you need to keep in mind So since my time is running out, I'll move fast. So so these absolute values are also considered. You can take these absolute values. Now, actually, the rule in and rule out values are explained. So these rule in and rule out values are assay related. You know, that's why I told you there are different assays given by different manufacturers. So so that expressed in different forms. So with regard to that, you can have rule in. So if the levels are higher than that particular level, limit, then you can say that definitely there's a myocardial infarction. And then ruling out, so there you can say if the levels are below such limit, you know, that assay specific levels should be explored with regard to the analyzers available in your institution or your laboratory. So, for example, if it is Abbott Architect Analyzer, the Abbott Architect Analyzer has this rule in and rule out values specifically defined to that particular assay method. So, therefore, that value should be found out, and then you can consider these absolute values and then explain these changes as well. All right. So you need to keep in mind that you know, there are certain conditions which can give rise to troponin cardiac troponin I or cardiac troponin T other than the myocardial infarction. Some of the examples are here. You know, so myocardial ischemia, you can get that, and these in tachyarrhythmias or bradyarrhythmias, cardiogenic or hypovolemic shock, respiratory failure, severe anemia. So these are some examples, and totally non-myocardial causes are also there. Stress, severe pulmonary embolism, sepsis, renal insufficiency. So this is very commonly, you can commonly see this condition, and infiltrative conditions like amyloidosis. So, and then even in athletes, even you know, in athletes like marathon runners, they have a physiologically high level of troponin. So you need to keep that also in mind when you are interpreting these results. You know, certain entirely non-myocardial causes are also there. But you can differentiate by repeating the value. If you see a rise more than the RCB value, to be very simple, you know, but then this you need to keep in mind that, you know, there are protocols explained, but simply you can take this RCB value. RCB value, if it is more than the RCB value or reference change value, then it's significant. But in these kind of cases, heart failure or renal insufficiency, the values don't change. So this RCB change is not observed in about 1 hour or 2 hours interval time. All right, so we go into this CK. CK is the creatine kinase, and I told you there are 3 isotypes, and we are interested on CK-MB as a isoform. And this CK-MB sensitivity is only about 50% with regard to AMI when it is tested early. So I'm talking about the early stages. So within about 3 hours time. So so if you test even in 3 hours, so this would be the sensitivity level. But if you measure in about 6 hours time, the sensitivity changes, sensitivity improves. but we need some early detection. So with regard to the CK, the early detection ability of the CK is not that great. So therefore, the popularity of CK is low, and these are the conditions where you see elevated levels of CK in conditions other than the myocardial infarction. So so you need to keep that also in mind. And so if you have some problem like this muscle trauma, rhabdomyolysis, and if you want to make a differentiation whether this heart is involved in these kind of cases, the considering the percentage of CKMB to the total is important. So the CKMB percentage, if it is more than 2.5, actually you need to consider the involvement of the myocardium. If it is more than 6%, actually you can rule in a myocardial problem. Myoglobin, another substance coming in this, coming from heart muscles, but unfortunately, it is not only coming in heart muscle, it comes in smooth muscles and skeletal muscles as well. So therefore, the specificity of this kind of a substance is low. I'm not going to go into detail, and LDH is a marker which has been used somewhere in 1990, as I told you earlier. But you have seen the elevation of LDH. The elevation levels are very low at early stages, but it as a late marker, it can be useful certain times. But troponin lasts for about 10 days. Compared to that, LDH lasts for about 7-8 days. So still, troponin perform better. So now, because of that, troponin has gained the popularity over all these cardiac markers. But new cardiac markers are coming in. As I explained you, ischemia-modified albumin, ischemia-modified albumin sensitivity and specificity are much greater in these cardiac ischemic conditions. So it's a coming up marker, and this another one is heart type fatty acid binding protein. Heart type fatty acid binding protein is similar to myoglobin, but it's more specific and it's more sensitive. So just before close up, you need to know a little bit on the markers of heart failure. Markers troponins as well as BNPs, brain natriuretic factor, can be used, but brain natriuretic factor is more specific. So therefore, brain natriuretic factor is more popular. One type of brain natriuretic factor is NT-proBNP, that is the secretory stages after secretion. Is pro-BNP part of the peptide chain. This is a polypeptide part of polypeptide chain. At the N-terminal end is broken, leave behind, broken in the when it is secreted into the blood. So this when it is broken, it is called brain natriuretic factor. But before breaking it, it's called pro-BNP, the pro-BNP stage. So both analytes gives you the same information, but the difference is pro-BNP is more stable. So if you want to if you expect some kind of a delay in your transportation or storage system, analytical system, or if you have problems with the staff, it's the more stable analyte pro-BNP is better. So having that, I conclude my presentation. Thank you very much. I don't know whether you have time for questions. It's up to the organizers.
Thank you, sir, for that very informative lecture. I'm afraid we are very behind the time. Actually, the count on high sensitive troponin troponin was very important for our listeners, as most of our laboratories have moved on to HS troponin. So thank you very much, sir. Without further ado, we'll move on to the next lecture. Tumor marker is an irreplaceable arm in the cancer management. To discuss about the tumor markers and other novel biomarkers, I cordially invite Dr. Rajita Samarasinghe, past president, CCPSL and consultant chemical pathologist at Apeksha Hospital, Maharagama, to deliver her lecture. Over to you, madam.
Thank you, Dara. Good morning. Basically, I will be talking about what is the clinical significance of tumor markers, actually how to get the best use of tumor markers. So this is the definition. Now, as the definition goes, it should be something that you would be able to measure in the serum or blood. So, and it should be able to differentiate a tumor from a normal tissue. And usually a tumor marker is a substance which is produced by the tumor or produced by the host as a response to the presence of the tumor. So what are the uses of tumor markers? One, the most important one actually, the most important in the sense, this is the part where you misuse it. That is to aid in the diagnosis. Now, the take-home message at the end of this lecture is not to use tumor markers to diagnose only. It is not a diagnostic marker. It has to be, it has to come with other diagnostic criteria like your histological findings and imaging findings, not just the tumor marker values. I will be talking about the reasons for that, but please make a note. The main use of the tumor markers are to aid in the diagnosis. Then in the follow-up of during treatment, in the follow-up and in the monitoring, and at the time of the diagnosis to predict the prognosis, and evaluating the success of treatment using the T-Hub, and finally the least important use is in the screening and in case findings. So I will start with I will start with the screening procedures, because most people think tumor markers can be used for screening, but it is not for screening. So I will start and finish off from the screening part first. So a marker to be a good marker, it should have 99% specificity and 99% sensitivity. That is, there should be minimal false positives and false negatives, right? But you know, when you take a cancer type, the prevalence is low, not the cancer as a whole, a specific cancer type, right? When you compare that to other non-communicable diseases, that one type of cancer, the prevalence is still quite low comparatively. So you will get as many false positives as well as false negatives when you use a screening tool on a disease where the prevalence is still low. That is why the marker, these tumor markers are not for population screening, because the prevalence is low, because of the prevalence of a given malignancy is low, and making the specificity and sensitivity above the agreeable level. So what are the uses in screening, or uses of the tumor markers in screening and case finding? First, we can use, I will give you some examples in that. First, you can use PSA to screen men over 50 years of age, which is actually happening at the moment. For men over 50 years of age, we can use, and being used in some other countries, and there is a talk about using PSA to screen in Sri Lanka also in males over 50 years of age. And in the case of case finding, Now, this is the only instance where we can use a tumor marker for screening, right? And in the case findings, we can do in high-risk individuals. For an example, again, fecal occult blood we can use in patients with a family history of bowel cancer. And again, PSA we can use for men over 40 years with a family history of prostatic cancers, right? And in sexually active women, we do the pap smear. Again, we can use that pap smear as a tumor marker. And in the family members of medullary carcinoma of thyroid, we can use calcitonin as a marker to screen to do case findings. And in chronic hepatitis, alpha-fetoprotein, again, to use as a case finding tool. Now, these are not screening, right? These are in case finding. Screening is only PSA for men over 50 years of age. So again, another thing I have to emphasize is now I have put you methods that we use to measure tumor markers, which are immunoassays, immunohistochemistry, FISH, a molecular biological method, enzyme assays, and HPLC, which is high performance liquid chromatography. Now, except enzyme assays, all the other four assays are extremely expensive, right? The per test cost, just only the per test cost without any overheads will come to about 2,000 to 3,000 rupees. So please don't use these tumor markers irrationally. You have to have a rational reason to use tumor markers. So please make sure these methods are very expensive, and even in the government sector hospitals are done this free of charge. So when you are requesting a tumor marker testing, please do it rationally. So there are several types of tumor markers. I will be talking about biochemical markers, but there are histopathological markers. Those are your immunohistochemical markers. And there can be genetic markers, which are oncogene products of any other oncogene suppressor gene mutations, right? Now, at the moment, in the near future, most of the oncologists will not be using our biochemical markers, right? They will be going into genetic markers because there are certain instances where we cannot use biochemical markers because of the low sensitivity and specificity. So the genetic markers are the future. So there are several types of tumor markers. Enzymes and their isoenzymes are there, hormones, oncofetal antigens, carbohydrate antigens, blood group antigens, proteins, receptors, and cytochromatins. So when we talk about enzymes are the historic tumor markers, very historical tumor markers. We now hardly use any enzymes because they are very late markers. Once these enzyme levels start to rise, the patient has already metastasized. Another thing is these enzymes are not very specific. So they have given some examples for enzymes: alkaline phosphatase, acid phosphatase, lactate dehydrogenase, PSA, and neuron specific enolase. Out of these 5 enzymes, I will be talking about LDH, PSA, and NSE only because the other 2 are not exactly, we cannot call them exactly tumor markers now because we have better markers now. But historically, we have been using these 2 markers quite widely. So PSA, now we all know, it's a very organ-specific marker. It's an enzyme, it's an organ-specific marker, and prostate is the only organ which produce PSA, right? So it is organ-specific. And it has 2 molecular forms. One is majority complex with alpha-1 anti-chymotrypsin or with alpha-2 macroglobulin. So, and there is a little amount circulating as free PSA. So what we measure as total PSA, or if you request PSA, what we measure is this total PSA. And most of the immunoassays measure this PSA and ACT complex PSA, or what we call total PSA. So unless you specify, unless you have requested at free PSA, if you have requested at PSA, we will be measuring this total PSA. So when we take PSA, it has a T half of about 24 hours. And since it is produced by the normal prostate gland, right? Any procedure leading to a prostatic stimulation could be a transrectal biopsy, ultrasound, transrectal ultrasound scan, and or TURP or radical prostatectomy. All these procedures can lead to a certain degree of damage to the top prostate gland, and these will lead to release of PSA into the circulation. So if a patient comes to you, if you think that you need to request PSA from a patient who has undergone any of these procedures, please wait for about 2 to 3 weeks after the procedure to give some time for PSA to get back to normal. Otherwise, invariably, you will get a higher PSA value, right? And prostatitis and benign prostatic hypertrophy and acute urine retention can also increase PSA, as well as digital rectal examination of the prostate. Now, it can also will lead to certain amount of stimulation, and some say even after a PR examination, you can have a minute elevation of PSA in some patients, which can be a problem during interpretation, because if the PSA value is elevated, if there's a slight elevation of PSA, and if the patient has come to you for a digital rectal examination, you won't know whether this elevation has been due to this prostatic stimulation or due to something due to early malignancy, right? So if the interpretation issue, because of this interpretation issues, it's always better to wait 2 to 3 weeks after any of these procedures to do a PSA. So what is the use of a PSA as a tumor marker, right? Now you all know, once the patient comes to you with the prostatic carcinoma, right? First, this is annual PSA screening for prostatic cancer. That is, once the patient is having a prostatic malignancy, right? There will be a follow-up after the patient is totally recovered. So there will be annual PSA screening of prostatic cancer, and we use total PSA for screening and for monitoring of prostatic cancer. Now, once the patient is totally treated from the malignancy, we do initially once in 3 months, after that once in every 6 months, and then we do the annual thing. So when we do this follow-up and screening thing, we use the total PSA. So what is the use of this pre-PSA? Now, pre-PSA, we use to differentiate levels of pre-PSA, levels of PSA that are in the gray zone. Now, for an example, you have a patient with a PSA value of somewhere around, let's say about 6 or 7, right? 6 or 7 nanograms per liter, and the reference range is usually, we have an age-adjusted reference range, but usually we expect the values to be less than 4, right? So in this patient, you have a value of about 6. Now, initially, those days, we used to do a biopsy. We used to do a biopsy because when the values are between 4 to 10, we do a biopsy to see whether the patient is having a malignancy, right? But sometimes these prostatic malignancies are multifocal. Even though you do a guided biopsy, there is a chance of missing the site, right? And it is an invasive procedure also. So in those patients, these are the type of patients that we request the free PSA level, right? Now, even free PSA, we don't do the value only. We have to get the percentage free PSA. That is free PSA divided by total PSA into 100. And that will give you the percentage free PSA. Patients with carcinoma prostate will have a low percentage free PSA. Right? Lower the percentage PSA, high chance of being a malignancy. Higher the percentage PSA, low chance of being a malignancy, and more chance of that being a benign prostatic hypertrophy. Right? So keep in mind, free PSA we do only once. That is to differentiate from benign to malignant one, and it has to come with the as a percentage of total PSA. Free PSA value alone will not tell you much. So you have to have it as a percentage, and you do it only once. Once the CA prostate is diagnosed, you can do the follow-up and other procedures using the total PSA value. So to increase the accuracy of PSA testing, we use age-adjusted cutoff values, right? Because benign prostatic hypertrophy is a disease of aging. Older the person, larger the prostatic size, leading to higher PSA value. So when you come across the PSA report, you will see we have given the reference range according to a age group. Older the patient, higher the PSA value, right? And sometimes you can request for PSA density, that is PSA divided by prostatic volume detected by ultrasound scan, or PSA velocity, that is rate of PSA increase with time. If the rate of PSA is increment of PSA with time is very high, that means the patient is having a very aggressive malignancy or malignancy. Because benign prostatic, if the patient is having a BPH, rise will not be, there won't be a quick rise of PSA value. The other enzyme is LDH. Now again, that's an enzyme, and you know it's a group of isoenzymes where you have various tissues producing LDH. Red cells, white cells, liver, kidney, lungs, right? So it is not specific for one organ. So elevation of LDH in malignancy is non-specific, right? But we use here in the Apeksha hospital, we use LDH quite often as the to follow up patients with NHL and leukemia. Now we don't have any other marker, right? Let's say cost-effective marker to follow up these patients. If you want to follow up, either you have to go for a CT or PET scan, or do a biopsy or lumbar puncture, which is invasive and costly. But doing a LDH level is not a very expensive test. So in those patients, we do LDH levels in the follow-up, right? So and at the time of the diagnosis, LDH level correlate with tumor mass. Now you know in lymphomas, they are very high, very large, bulky solid masses. So at the time of the diagnosis, if this patient's LDH value is very, very high, it will tell you about the size of this solid tumor and provide a prognostic indicator of disease progression as well, right? But although we use this widely to monitor treatment, the value is questionable. Then NSC, neuron-specific enolase, that is found in tumors associated with neuroendocrine origin, right? Small cell carcinoma of lung, neuroblastomas, pheochromocytomas, carcinoids, medullary carcinoma of thyroid, melanoma, and pancreatic endocrine tumors, right? And this is helpful in assessing prognosis, monitoring, chemotherapy, and correlate with disease status. This is a very expensive markers, and we have less expensive markers to follow up those tumors. So we don't use it much, very often now. Then we go to the other group of tumor markers, hormones. Now ACTH is a hormonal tumor marker, which is used in the diagnosis and in the follow-up of pituitary tumors or any ectopic site, any malignancies present in ectopic sites producing ACTH. Like more than 50% of small cell carcinoma of lung will produce ACTH. So that is production of ACTH from an ectopic site. Another hormone is calcitonin. Now increased levels are associated with medullary carcinoma of thyroid. And calcitonin is most useful in the detection of familial medullary carcinoma of thyroid, that is in the case detections, right? And helpful in the detection of asymptomatic family members affected. These are the other hormones: cortisol, growth hormone, HCG, PTH, catecholamines, insulin, ADH, parathyroid hormone related peptides, which are both the ectopic endocrine products. So to get the maximum benefit as a tumor marker, you all must adhere to protocols in specimen collection. When you want to do either ACTH or especially ACTH and parathyroid hormone, please contact the laboratory and get the protocol for sample collection, because these hormones are very labile, and if you don't adhere to the protocols, you will not get the necessary information from the assays. Then HCG or human chorionic gonadotropins. It's a glycoprotein consisting of two alpha and two subunits, alpha and beta subunit, and beta subunit is unique to HCG. So it increased levels are found in pregnancy and trophoblastic diseases and in germ cell tumors. So highest levels you see in trophoblastic diseases. Trophoblastic diseases are HMOLs and choriocarcinomas. So you will be seeing very high levels in these HMOLs and choriocarcinomas. And in moderate elevations are seen in germ cell tumors and non-seminamitous testicular carcinomas. HCG is increased in almost all with trophoblastic tumors, right? So it's a very good tumor marker in a patient suspected of trophoblastic tumors. But in 70% of patients with non-seminamitous testicular tumors and less frequently in those with seminomas, about 28%. So if the patient is now, you all know trophoblastic diseases occur. Initially, the patient will present you with all the signs and symptoms of pregnancy, right? So how to differentiate that with pregnancy? Now, serum and urine HCG levels, they will keep on rising in pregnancy as well as in trophoblastic diseases and will peak in the first trimester, close to about 90 days, right? If the patient is having a normal pregnancy, the levels will start dropping. But in trophoblastic diseases, right, in HMOLs or choriocarcinoma, there will be a progressive rise even after 90 days, right? Even after 90 days, the rise will be progressively high. And other thing is, if you want to detect the trophoblastic disease early, because these are very invasive tumors, usually if the patient is having a trophoblastic disease, the HCG level will be higher than the patient's period of amenorrhea. Right? Now, there is a different ranges we are giving according to the period of amenorrhea. The patient is having a trophoblastic disease, the level will be higher than the period of amenorrhea, right? And it has a T-half of 12 to 20 hours. I will be talking why this T-half is important, right? So we use again this as a prognostic marker. If the time at the time of the diagnosis, if the beta HCG value is very high in 1,000 or in 100,000, 200,000, it is a good indicator that the trophoblastic disease has gone to lung or brain with lot of invasions and metastases. And this is a very widely used marker to monitor choriocarcinomas and HMOLs, because it has a T-half of 12 to 20 hours. So what we do is, when the patient is started on therapy, we do the second value after 48 hours. If the patient is responding very well to this, the chemotherapy, the value should halve, right? If the patient has started with 100,000, after 48 hours, the value should be less than 50,000 if the patient is responding. Then again, we do it after 48 hours. Again, the value should be less than half the previous value. Other one is, you all know, these trophoblastic diseases are very invasive diseases and they can have brain metastasis. But HCG do not cross the blood-brain barrier. So if the patient is having a brain metastasis, the metastasis will be producing beta HCG. So we can do a serum and CSF beta HCG value and to see the ratio, right? Normally, the ratio serum to CSF ratio is more than 16:1. So again, other one is the reporting. Now, there are three types of beta HCGs that we can measure. One is just the intact molecule, right? Alpha and beta subunit, both subunits, we measure the intact molecule. And the other one is the total beta HCG. This is the intact molecule and the free beta subunit circulating in the blood. So this total beta HCG will measure the intact HCG plus free beta subunit. The third one is free beta subunit only. Right? So normally what we measure in our laboratories, both in the private sector and the state sector laboratories, is total beta HCG. That is your intact HCG and free beta subunit. We don't measure the free beta subunit. As a tumor marker, free beta subunit is a preferred. As these trophoblastic tumors and malignancies, the germ cell tumors, they produce the free beta more free beta subunit. But we don't measure the free beta subunit because of the cost, and patients tend to change the laboratories when they are following up. So if you start measuring free beta subunit, and next time when he goes to the local hospital and get it measured, and they get the total beta HCG measured, the interpretation will not be easy because the reference ranges are different. Then oncofetal antigens. Those are antigens produced during the fetal life, and during fetal life, they have those in very high concentrations and they disappear after birth, right? In malignancies, they reappear due to certain gene reactivation as a result of malignant transformation of cells. So these are the commonly used oncofetal antigens, your AFP, alpha-fetoprotein, and CEA, carcinoembryonic antigen. It's a marker for hepatocellular carcinomas. And when the patient is having a hepatocellular carcinoma, usually levels are more than 1000, right? Now, and you can use AFP in germ cell tumors, which is non-somatomatous germ cell carcinomas, and in hepatoblastomas. In healthy, AFP is usually less than 10 micrograms per liter. And in newborns and neonates, usually higher. Now, for neonates, we give a separate reference range of less than 30 because neonate takes time to clear off maternal AFP developed during the fetal stage, right? But when you do sometimes we come across samples from newborns. Now, newborn AFP values are very, very high, and we don't have a reference range for that also. But if the newborn AFP value come as a very high value, we can't possibly say that the newborn is having a neural tube defect or some of the hepatoblastomas, because we don't know whether the newborn is expressing the fetal AFP. So in those patients, we will have to repeat the AFP value in some given time, maybe one week. After that, within 1 week, if the AFP values has not come down, if there is a further increment, then we will have to suspect a malignancy or a neural tube defect. If it is a normal infant, normal newborn, the value will be, second value will be lower, right? And as I spoke earlier, AFP level increases during pregnancy. And now here we have come why we can't use these tumor markers to screen or use for to diagnose only, because it can certain benign conditions and certain non-malignant non-pathological conditions, non-malignant conditions can increase AFP levels, such as hepatitis and cirrhosis. But in all these non-malignant conditions, levels are usually less than 200 micrograms per liter, right? So if the values are less than 200 micrograms per liter, usually it could be due to a certain non-malignant condition. If it is between 200 to 500, you have to suspect it. As you have to suspect a hepatoma, right? If it is more than 1000, usually it's a hepatoma. In hepatomas, AFP levels are very, very high. So if the patient comes to you with the clinical features and immunological evidence of a hepatoma, ideally the value at the time of the diagnosis should be more than 1000. And you can assess the size of the hepatoma as well, right? From the AFP value at the time of the diagnosis, you can get an idea about the hepatoma size from the initial AFP value. And again, CSF also you can measure AFP, because certain germ cell tumors again can spread to meninges, and then you can get the AFP level, and you have to have the ratio, and if the ratio is more than 1 to 40, you have to suggest the CNS involved. And both these tumor markers, AFP and beta HCG, both we use for germ cell tumors, right? AFP is increased in yolk sac tumors, AFP plus beta HCG is increased in inguinal carcinomas, and AFP is normally seminomas, whereas HCG is increased in 10 to 30% of patients. And neither marker is increased in teratomas. Then CEA, again, it's a fecal glycoprotein re-expressed in tumors, right? The main clinical use is a marker for colorectal cancers. Now, this is CEA is very important in patients who are going in follow-up after treatment, right? A patient who has had a high CEA at the time of the diagnosis and after surgery and chemotherapy who has a normal CEA. This is a very good marker in the long-term follow-up and to detect early relapses. Now, and again, at the time of the diagnosis, before the treatment, if the CEA level is quite low or normal, it will predict about lower metastasis if the pre-therapy CEA is normal. But if the high initial CEA is high, higher metastatic incidence, and you have to monitor, and you use this to monitor response again also. In 2/3 of patients, right, an elevated CEA may be the first indication of a relapse. And it says CEA levels start to rise about 3 months prior to even the appearance of your radiological evidences. Before the appearance of radiological evidences, if you carefully follow up a patient using CEA, in 2/3 of patients, you will see an elevation 3 months before the appearance of the radiological evidences, right? But again, it is not specific for colorectal carcinomas. It is found in about 30 to 50% of breast cancers, small cell carcinoma of lung, mucinous adenocarcinoma ovary, and adenocarcinoma cervix. So you can see it is not specific for colonic cancers, right? And sometimes certain patients with colonic cancers, even with metastasis, right, a small percentage will not express CEA at all. So in those patients, you can't use CEA even to follow up. Those who have not expressed CEA, even at the time of the diagnosis, you can't use CEA to follow up, right? But in 30 to 50% of breast cancers, CEA can be used as a secondary marker because for breast cancers, we don't have a good blood marker. And again, then there are certain non-malignant or benign conditions where you find high CEA also, right? As in elevation, you will see a small elevation of CEA in smokers because smokers have emphysematous lungs. In emphysema, CEA levels tend to elevate, right? So you will see in smokers and in emphysema, higher level of CEA. And chronic obstructive pulmonary diseases, again, high CEA. Inflammatory or peptic bowel diseases, hepatitis, cirrhosis, renal failure, and even in fibrocystic breast disease, you can see CEA elevations. Now, even though I have said usually the levels are less than 10, maybe you will come across values around 20, right? 20, 25, even in those patients, right? Now, when you see the reference ranges also in the CEA report, you will see we have given reference ranges for 2 groups. One group is for non-smokers, slightly lower value, like should be somewhere around 2.5 nanogram per ml, and for smokers about 5, right? Double the value given for non-smokers. So because of the elevations occurring in the benign diseases, which are your false positives, and the number of tumors that do not produce CEA, false negatives, CEA testing should not be used for screening. So if a patient comes to you with a alternative bowel habits, without doing other investigations, please don't do a CEA. Then carbohydrate antigens, also known as cancer antigens, right? They are high molecular weight. And there are several types of carbohydrate antigens, but I will be talking about mostly commonly used types, which are CA125, 15.3, 19. And 19.9. So CA125 is a marker for ovarian and endometrial carcinomas, and you have you have a different stage of less than 35, right? And you will have more than 80% of epithelial ovarian cancers expressing CA125. But you will not get CA125 elevations in endometrial types. Usually they don't express because they are not epithelial. Again, not specific. You will see CA125 elevations in all the other type of malignancies. And please note the non-malignant or non-pathological conditions like follicular phase of the menstrual cycle. Endometriosis, you will see quite a high value of CA125, cirrhosis, hepatitis, and pericarditis. So again, in ovarian carcinoma, very helpful in the detecting the tumor size at the time of the diagnosis, as a prognostic marker, right? And in assessing the response to therapy. You do it during chemotherapy to find out the whether the values are coming down, and detecting residual disease following initial treatment, and detecting recurrent metastasis. And please keep in mind, even within the rise of CA125 value within the reference range is significant, right? Within the reference range, elevation of CA125 within the reference range is also significant. This is not a very good which is not a very good marker. It's a marker for breast carcinoma, right? And you will see about 20% elevation in localized disease and 80% in metastatic disease. So it is not a very good marker because incidence of elevation is very, very low. 19.9 again is a marker for colorectal and pancreatic carcinoma, and 55% of our population is Lewis blood group negative, so they will not be expressing 19.9. Again, in the help to aid the diagnosis and in the monitoring and to detect the relapse, right? And again, not a very sensitive and specific marker. You can see a very mild increase in pancreatitis and early stage of pancreatic cancer. So not good for diagnosing early pancreatic cancers. Then there are certain proteins. Beta-2 microglobulin is a prognostic marker in multiple myeloma and other blood malignancies, right? And it found in plasma, serum, and urine. You can do beta-2 microglobulin levels in all three, and it's a very accepted prognostic marker in multiple myeloma at the time of the diagnosis, and done only once at the time of the diagnosis. Again, I told you the multiple myeloma, lymphomas, right? And thyroglobulin. Thyroglobulin is a very important marker. It's a protein. It is tissue specific. Like your PSA, this is the other only organ specific tumor marker, which is specific for thyroid gland and produced by epithelial cells. So it's the marker for differentiated thyroid carcinoma. That is your papillary and follicular carcinoma. So if in the patient with thyroid malignancy, first you remove the gland and you give radioiodine, right? So then you assume the patient doesn't have any thyroid tissue. That means there should not be any thyroglobulin levels, right? So if there is a persistently high levels of thyroglobulin, that will indicate you incomplete resection or metastasis. So this is a very good marker in the follow-up of thyroid carcinoma, differentiated thyroid carcinomas. So but we have to keep in mind, this is elevated, this can be elevated in any condition that can damage the thyroid gland. Could be an inflammatory condition, thyroiditis, vigorous thyroid examination, thyroid biopsy, FNAC. So any of these conditions can lead to elevation of thyroglobulin. So please don't do thyroglobulin to diagnose thyroid malignancies, right? That's another take-home message, especially after an FNAC. Don't request thyroglobulin because invariably thyroglobulin value will be high after FNAC. Another thing is, after patient undergone this iodine therapy, 30% of these patients develop anti-thyroglobulin antibody. Anti-thyroglobulin antibody will interfere with thyroglobulin. So thyroglobulin and anti-TG antibodies should be done together, And if anti-TG antibody levels are higher, anti-TG antibody level is used as the tumor marker and not thyroglobulin in those patients. And you have to do a TSH stimulation by stopping thyroxine intake or by giving recombinant TSH before doing the thyroglobulin assay. This is a very rare group of tumors, neuroendocrine tumors. You have two groups. One occur independently without the occur independently of production of regulatory peptides by normal or tumorous neuroendocrine cells. These are known as broad spectrum markers: NSC, chromogranin A, pancreatic polypeptide, alpha HCG, right? And specific markers including regulatory peptides like gastrin, glucagon, and insulin. Now you all must have seen chromogranin A, right? And gastrin, glucagon, and insulin. Those are the markers that we use widely in neuroendocrine tumors. So majority of patients with neuroendocrine tumors present with metastatic diseases, right? So there is a need for more specific and sensitive biomarkers in the future. So when you say chromogranin A and B, the specificity is very, very high, right? But other one, pancreatic polypeptide NSC, intermediate, and alpha and beta HCG are very, very low. So I will talk a little bit about chromogranins because we do chromogranins here, right? It's a family of neuroendocrine secretory proteins produced by chromatin cells of the adrenal medulla, right? And enterochromatin cells like beta cells of the pancreas. And it is a precursor for several functional peptides. So there are several in this chromogranin A, but chromogranin A and B are the most clinically utilized. And at the moment, we have methods to measure chromogranin A only. B is the better one, but methods are available only for chromogranin A only. Right? And it is the mostly applied marker in carcinoids, which account for more than 50% of neuroendocrine tumors, right? With high sensitivity and specificity, but most must be evaluated in relation to other diseases. Chromogranin A is elevated in pheochromocytomas, carcinoid syndromes, paragangliomas, neuroblastomas, and gastroenteropancreatic tumors like gastrinomas, glucagonomas, and insulinomas. And most chromogranin A levels show a very high correlation to the tumor mass. If the tumor is, if the carcinoid tumor is very, very large, you will have a very high chromogranin value at the time of the diagnosis, as well as in any other markers. This is very helpful in the monitoring of the therapy and in the long-term follow-up. Another thing is, this is the most important thing that you have to keep in mind. The interpretation of elevated chromogranin is that it has to be done with caution, right? Because it can occur in normal individuals as well as with neuroendocrine tumors. It can vary with diet and physical stress, right? Physical stress can increase chromogranin A. And there are other pathologies as well. Now, of the given pathologies, the most important one that you have to keep in mind is therapy with proton pump inhibitors. You know, it's an over-the-counter drug, right? Omeprazole, pantoprazole. A lot of patients are in omeprazole and pantoprazole, and patients with carcinoid signs and symptoms, with the signs and symptoms of carcinoid syndrome, like sweating, hypertension, they are invariably will be given proton pump inhibitors for gastritis. So, in those patients, the assay procedure we have at the moment, right? We have at the moment is a very basic assay procedure. It's an immunoassay called ELISA. So that assay procedure will interfere with these proton pump inhibitors. So I have come across many patients giving very high values and going back to the drug history to see the patient had been on omeprazole or pantoprazole. So you have to ask the patient to stop that for at least for about 2 weeks or maybe even 1 week will be enough, I think, to do the chromogranin A value, right? So please keep that in mind. Out of all the other given pathologies I have given, therapy with proton pump inhibitors is the main worry at the moment. So other malignancies which can elevate chromoganins are lung cancers, breast, liver, and prostate. So it is again not a specific marker to screen, right? To screen patients. So I have given a small summary of the recommended tumor markers for specific type of cancers. Now for hepatoma, ovarian cancer, but breast cancer, you can see CEA we can use because 15.3, as I mentioned, is not a very good marker. Again, cancer also we can, carcinoma, pancreas, we can use CEA. And for non-seminal metastasis, testicular cancer also we can use CEA. Prostatic cancer, again PSA, and H-small or cholangiocarcinoma, beta SCG. So the take-home message is we don't have an ideal marker at the moment. There's no ideal tumor marker is known so far, right? But if the patient has a known malignancy with the elevated tumor marker, that tumor marker is the best to follow up the patient. Just the blood sample, right? And most of the using properly, if properly used, most of these tumor markers will tell you in advance whether the patient is developing second metastasis or getting the malignancy back. So, and the best approach is you have to take a good history, thorough physical examination, use a battery of markers. Sometimes you might need to use more than one marker, right? And use confirmatory investigations, histology, radial and radiological investigations, right? So this is in the diagnosis, but in the follow-up, in the follow-up is actually the main use of tumor markers in my experience is in the follow-up, right? Because it is non-invasive, just a blood sample for the patient, right? And most of the tumor markers will give you about the tumor recurrence well in advance for the oncologist to intervene. Thank you very much. I don't know whether I have any time for questions.
Thank you, Madam, for that excellent account on tumor markers with a special touch on the practical aspects. I'm afraid we don't have much time for the questions,
Okay.
Madam. We are quite behind the time today. Without further ado, I warmly invite Dr. Dulani Jayawardena, President-elect, CCPSL, and Consultant Chemical Pathologist at National Hospital Kandy, to deliver her lecture on interpretation of renal function tests. Over to you, Madam.
Thank you, Dara. Can you see the slides?
Yes, Madam. We can clearly see the slide.
Okay. First of all, I must thank College of Chemical Pathologists for organizing this very useful workshop. And we have come towards the end of the second day. I hope that the participants are not saturated with the knowledge, and hope that there is some leftover space to grab some facts. So I'm going to discuss about the interpretation of renal function test during next half an hour time. So with the term renal function test or the RFT, I think most of the time it is misused. RFT, when we get the request with renal function test or RFT, different laboratories, they perform various combinations of panels of tests. But by doing so, I think we are mistreating the kidney. The kidney is the one of the main organ that doing enormous function to maintain our health. So we have to first identify what are the functions of the kidney before going into the test. So first we going to identify the functions of the kidney. Then we will discuss what are the tests that are important to assess the renal function. Then we have to consider what are the things that we should know in the interpretation of those tests. So what are the essential functions of the kidney? As you all know, mainly the excretory function. So that is the filtration of waste product from the blood and excretion via the urine. Then it happens at the kidney as the main function of the kidney. Then not only that, but the kidney also contribute for the homeostasis of the body. It does it by regulating the body fluid status, and it also contribute to maintain electrolyte balance and also the acid-base status. Then apart from all these excretory function and homeostatic maintenance, it also has an endocrine function because it produces some hormones. That is mainly the erythropoietin synthesis, and also it secretes renin from the juxtaglomerular apparatus in the kidney. And it is also the place for vitamin D activation. And not only that, certain hormones like ADH, aldosterone also act on the kidney for its action. So therefore, there are several functions that happens at the kidney. Then we have to look into tests that we should perform for the assessment of all these functions. So first, we will discuss about the excretory function because it is the main function of the kidney. So when we're going to discuss about the formation and the excretion of urine, first we have to remember the basic functional unit of the kidney, that is the nephron. So nephron has the, as your basic knowledge, it has the glomerulus, then the tubular system, collecting ducts, proximal tubule, loop of Henle, then the distal tubule. So there are several mechanisms happening at various places in this nephron in order to maintain the homeostasis and the formation of urine. So we can divide these functions like glomerular filtration, tubular reabsorption, tubular secretion. So all these functions need to be at the optimal level to kidneys to function properly. So why we are doing renal function? What is the use of doing renal function? So in a normal person, we don't know the functional capacity of the kidney because the symptoms appear very late. So for the assessment of the functional capacity of a person who appears healthy or normal in day-to-day life, but we can do certain tests and we can identify it before it becomes symptomatic. Then if we diagnose the person with renal disease, then to confirm that diagnosis, we suspect the diagnosis with the certain clinical features. Then for the confirmation of diagnosis, we can perform certain tests. Once it is diagnosed, then we have to assess the severity and we have to monitor progression of the renal impairment. Then again, certain list of tests are useful. After starting the treatment, then we have to assess the effectiveness, whether it is effective, how the kidney function is performing, or sometimes with treatment of some other drugs, it can affect to the kidney due to its toxic effects. So monitor all these functions. We need assessment of renal function test. So disease conditions that affect the kidney. These are the very common conditions we encounter in the hospital or in the laboratory. Many requests come from different units with different conditions affecting the kidney. So we can categorize them as pre-renal causes, renal causes, and the post-renal causes. So pre-renal causes are mainly due to reduced blood flow to the kidney. It can happen at due to shock, due to any cause, or maybe due to severe blood loss. And most common condition, like most of the non-communicable diseases and long-term problems of the kidney happen due to renal damage to renal tissue, like glomerular basement membrane or tubular systems can get damaged, like glomerular nephritis, diabetic or hypertensive nephropathy, and the tubular damage due to toxic substances. All these cause damage to the kidney functional units, and it can cause renal diseases. In the post-renal causes, like in the urinary tract, any obstruction to urine outflow, like ureteric stones, prostate cancers, all these can cause uh, back pressure on the kidney system and damage to the tissues and cause renal diseases. So all these conditions need to be assessed with the renal function test. So what are the information that we can gather from these tests? So by doing these tests, we can get an idea about the basically renal glomerular function. That is the basic functional unit of the kidney for the excretion. Then also we can get an assessment about the tubular function, secretion, reabsorption, whether it's happening properly. Then we can get an idea about the glomerular filtration rate. So that is the main indicator of the renal functional capacity. And we can also get an idea about urine. We can measure, we can study urine because it is a non-invasively collected sample, and we can get a lot of information about the kidney by analyzing urine. And we can also, by doing renal function test, we can also get an idea about the renal blood flow. So we can get a lot of information about the kidney with those tests. So this is the commonly used test panel for the renal function test, like serum test. When we get the request for renal function, lab will perform various combination, depends on their laboratory decision setups. They will perform. So the serum creatinine, serum urea, uric acid, and the sometimes protein, albumin, and the electrolyte, sodium, potassium, chloride, phosphate, calcium. So all these serum parameters have various changes with the change of renal function. And when we produce a laboratory report with the patient's value that is produced by the analyzer, we will give a reference range. So we have, when we get a report, we have some data, right? So when we get a patient report, we have a data. We have a value for the patient's creatinine. We have a reference range and for each analyte. But can we interpret only with this data? These are only data. So for the interpretation, we need some more. We need to always interpret the report with the clinical context of particular patient, right? Clinical context of particular patient. So that's why we always request patient's clinical history and patient demographic data, patient, whether it is, what is the age, what is the sex, so everything, what are the drugs patient on, what are the evidence given by the other investigation, everything must be there for the interpretation of a report. So we will go to the test one by one. So the commonly used test for the assessment of renal function is the creatinine. So creatinine is produced from the muscle creatine in the body, and it can, by the conversion of creatine to creatinine, and it will be excreted only by the kidney. So it's a good biochemical marker for the assessment, but it has some pitfalls, and I will discuss it later. And it increases with meals rich with meat because it's come from the muscle, and it can release from the muscle with vigorous exercise. And if the person is having an increased muscle mass, it may be with bodybuilding, some athletic activity, he might have an increased creatinine level. So it may be not within the reference range given by the laboratory. And when you know that when with the old age, there is a decrease in the muscle mass. So with the old age, we have to always interpret cautiously because these people have a low muscle mass. But if the person is having a normal muscle mass, there is no increase or decrease due to any condition that we have mentioned, and the creatinine will be pretty stable throughout the time. So that's why we are tell it as a marker with minimum intra-individual variation. But if we get a population between people, it can vary depending on the muscle mass and the other factors. So for the monitoring of individual renal function, so if we have a baseline value for the person, and from that onwards, we can keep monitoring with the creatinine to assess the renal function. But in the early renal damage will not indicate by the creatinine, and I will discuss it later. Before moving to that, we have to discuss a little bit on analytical aspect. I think previous lectures it was discussed. There are two methods that use for the analysis of creatinine. One is the Jaffe method, that is the older one, and it had a lot of interferences. As Dr. Manjula mentioned in the laboratory problems, there were a lot of interference with various analytes, bilirubin, ketone, glucose, and certain antibiotics can interfere with the Jaffe method. So the results that given by the analyzer may not be the true value of creatinine depending on the method. But the enzymatic method that is used for the measurement of creatinine is more reliable because it has less interferences than the Jaffe method. So if you get a creatinine report, you must always think about what is the method of analysis of this creatinine value. Then only we can do the interpretation. As the laboratory personnel, we are acting like a link between the clinician or the patient and the laboratory. So we always must have a knowledge about clinical behavior, like behavior of the certain analytes within the patient with various disease conditions, how this parameter will change. And at the same time, we must always have a knowledge about the analytical aspect. Then only when we can give a productive interpretative comment for the report. So this graph will show you the association of the glomerular filtration with creatinine. We are measuring the creatinine to assess the kidney functional capacity of the kidney. So the functional capacity of the kidney is mainly indicated by the glomerular filtration rate. That means number of functioning glomeruli within the kidney. So as you can see in this graph, in the early stage, so this patient's glomerular filtration rate is decreasing rapidly. But what happened to creatinine? It doesn't move rapidly. Actually, I have given the reference range in the two different units. So it's still remaining within the reference range. But what has happened? This patient's glomerular filtration has dropped by around 50%, but still serum creatinine value has not moved up. So that's why we are saying serum creatinine will not increase beyond the reference range until you get 50% of your nephrons damage. So it's not a good marker to identify the early renal damage. But once it's established renal failure, then it will move rapidly. So that's why it's good indicator for the assessment of chronic renal failure. So you have to remember this fact when you are interpreting the creatinine value. So by doing a population-based creatinine assay or study, we can't exclude that this person has no renal problem because it has a patient has a normal creatinine value within the reference range. So creatinine change can be due to any other causes other than the renal problem. Sometimes when the patient is in the ward or ICU setup, we need to do the refeeding, and creatinine can increase with that, and it can also decrease with certain conditions, especially if the patient is having muscle wasting diseases, myopathy, and a loss of muscle mass, and after surgery, starvation, treatment with corticosteroid. So these conditions can alter the creatinine values. So you have to interpret those results depending on the patient's clinical condition and especially previous value. The delta check is very important in the interpretation of creatinine. If you have the baseline value or the previous creatinine the patient has done sometimes earlier, it's very important. And in the pregnancy also, glomerular filtration rate increases and creatinine may decrease, especially in the first trimester. Then we talked about the glomerular filtration rate. So we use various methods for the assessment of the glomerular filtration rate because it indicates the functional capacity of the kidney. So it indicates the number of functioning nephrons which is remaining in the kidney, and the decrease in the glomerular filtration rate indicates the renal failure. So the earlier we used 24-hour urinary creatinine clearance. We asked the patient to collect urine for 24 hours for the assessment of glomerular filtration rate. Then we measure urine creatinine value, serum creatinine value. We measure the volume and we do the calculation for the 24-hour urinary creatinine clearance with adjustment for the body surface area. But it is a very cumbersome test and need to collect proper collection should be done, instruction should be given properly, and always to assess whether there is adequate urine amount collected during that period. So it's a cumbersome test. So now there is an alternative for the assessment of glomerular filtration rate. What is it? So it is the EGFR, or the estimated glomerular filtration rate. So it is not a measured parameter. So it is calculated by creatinine. So creatinine we can do in the serum, and we can, using the creatinine, we can calculate the estimated glomerular filtration rate. So it's the alternative for the formal measurement of creatinine clearance by the 24-hour urine collection. So for the calculation, there are various formulas which are derived from the population-based studies. Remember, it's derived from the population-based studies. So the formula has derived from the study, and it's depend on the study population that it was derived. So most of the formulas were derived from the population from the age 18 to 60. These formulas cannot apply for the extremes of age. So pediatric, you can't apply that commonly used formula for the pediatric population, and the very old people also with low muscle mass, we can't apply those. There are certain other conditions. If the person is having rapid change in renal function in the pregnancy, if the person is having like amputation, you can't apply those formulas. And we have to again remember, because we are using the creatinine value, which we have measured from the laboratory using certain assays. If the EGFR to be standardized, the creatinine assay should be standardized. So it should be traceable to the primary standard, or it should be the reliable creatinine assay with the standardized method. So what are the formulas? So there were several formulas used. Earlier we used the MDRD, Cockcroft Gold formulas, but now commonly use the CKD EPI formula. So CKD EPI formula, there are several CKD EPI formulas. You can use this formula, but you need the information, serum creatinine value, and the patient's age, whether patient is male or female, and whether it is measured by the standardized assay. And it's available like online calculator in your mobile phones. You can get online calculator for the CKD EPI equation. And if you have further tests like cystatin C, again there is another formula, that is CKD EPI with cystatin C. You can use that for more precise calculation. So those formulas are useful for the estimation of glomerular filtration rate. So as I told you earlier, it's mainly important for the assessment of chronic renal diseases. In Sri Lanka, we are having a big problem with chronic kidney disease of unknown origin. So we have to always every lab, even in the peripheries, we have to deal with assessment of renal function and the staging of kidney. For the staging, there are several stages from 1 to 5, and with the use of serum creatinine, we can calculate the eGFR, and with other clinical evidence of kidney damage, we can classify whether patient is on stage 1, 2, or 3A, 3B, 4, or 5. So depending on the stage, you can say what percentage of kidney is function. If it is stage 1, we have function of kidney 90 to 100% function may be there. But if you go for the stage 5, you have less than 15% functional capacity in the kidney. So by doing so, we can easily monitor the patients and we can plan the management. So then we will move to the other test that we are commonly used for the assessment of kidney function. Urea is synthesized primarily in the liver. So it's a byproduct of deamination of amino acid and it's eliminated in the urine. So because of that, it's a major route of nitrogen excretion. Sometimes the term blood urea nitrogen or the BUN is used for the measurement of urea, because you can measure the urea amount and convert it to the amount of nitrogen. So because urea is the major route of nitrogen excretion, but it's less reliable than the creatinine to assessment of the assessment of renal function, because it can be elevated in many other causes, because it's produced by the protein amino acid with high protein intake and the catabolic stage. It can increase, and if there is a GI hemorrhage, bleeding into gut, and because of globin fraction is there, can get increased urea in the blood. It also decreases with low protein intake like starvation, and some patients with liver diseases, and because the urea is synthesized from the liver with the urea cycle, and if there is a defect in the urea cycle or the liver disease, you can have a change in urea level, but it will not indicate definitely that it is due to renal problem. Then interpretation of urea, you have to always look into the liver and any other causes of possibility of elevation. So we usually consider creatinine and urea together, and we can calculate the ratio and see whether there is a change in the ratio for the interpretation of that function. Then the other requested parameter to assess the renal function is the uric acid. In the chronic kidney disease, it might increase, but it will not sufficient to cause gout at that level. But raised uric acid is a bad prognostic indicator for the chronic renal disease. So what are the other changes happen with the serum analytes with the kidney disease? Because most of the kidney diseases causes protein losing conditions due to the damage to the glomeruli. So you can, especially with the chronic kidney disease, serum total protein and albumin can get decreased. But in the acute kidney disease, you might get transient proteinuria, but sometimes you might not change the total protein and albumin. So you have to bear in the mind to interpret it accordingly. Then the other commonly requested parameter is the serum electrolyte, because electrolyte change with various conditions like with the hydration level and the kidney function and the intake of various electrolyte like sodium, it can change. So especially in the chronic kidney disease, we have to assess the electrolyte. In the chronic kidney disease, usually you get hyponatremia, that is decrease in sodium. Then there is increase in potassium, and chloride and phosphate also increase, but calcium get decreased because of vitamin D deficiency. This is another important marker for the assessment of kidney function, that is cystatin C. Though we are not doing it frequently in our laboratories in Sri Lanka, but it's a commonly used test for the assessment of renal function. As I mentioned earlier, it can be incorporated into the estimation of glomerular filtration rate for the eGFR with certain formulas. Cystatin C is a low molecular weight peptide. It's produced by all nucleated cells in the body, and its concentration in serum reflects the glomerular filtration rate more accurately because it's not influenced much by the gender or the muscle mass, but it may increase with the malignancy and the hypothyroidism and treatment with corticosteroid. And you can use with the relevant formula for the calculation of eGFR. Then the assessment of the glomerular integrity. Why we want to assess the glomerular integrity? Most of the conditions that affect the kidney tissue, like glomerular nephritis, any nephropathy, mainly affect the glomerular basement membrane. So you can get damage to the basement membrane. With the damage, certain molecules, including red cells, will move into the filtrate. So it will go to the tubular system and will excrete via the urine. And also certain molecules like albumin, other large molecular proteins also get into the kidney. So the albuminuria and proteinuria is a marker of glomerular damage. Then if it is severe damage, you get RBC also going into urine, and you can check dysmorphic red cells. When the red cells go into the damaged basement membrane, its shape get distorted. So those distorted typical red cells we can observe by the phase contrast microscopy ideally. So you can see the picture of the dysmorphic red cells, how it appears with the phase contrast microscope. Then we can predict that renal damage most likely due to change in the damage in the glomerular basement membrane. So it's very important to identify those things for the interpretation and predicting where is the damage in the kidney. Then we had to talk about proteinuria, because in the laboratories we measure albumin and protein by various methods. We can categorize like glomerular proteinuria, tubular proteinuria, overflow proteinuria. Glomerular means due to damage to the glomeruli, you get proteinuria. Then damage to the tubules will also cause proteinuria, and overflow is when you have an increase in the light chain protein, it will leak into the protein. So this is the albumin measurement. This was earlier talked by the different speakers. We say albumin less than 30 microgram per milligram creatinine is normal, but if it is above that, we say microalbumin, but it's the small amount of albumin, but it's more than 300, it's the clinical albuminuria. The other proteins, myoglobin, ketones, tubular proteins can identify in the urine. Then to assessment of the tubular functions, though we are not defining it as a renal function, we assess them like urine glucose and the urine amino acid urea, then the beta-2 microglobulin. All these indicate the function of the kidney, whether it is normal or abnormal. Then to assess the distal tubular function, we can do the water deprivation test. We can measure osmolarity. That will indicate the function of distal tubule. So by doing various tests, we can identify where is the problem of the kidney. So ultimately, we pay less attention for this test, that is urine examination. But if we can collect proper sample, like proper timely with proper container, and examine at the proper method at timely examination, we can get lot of information from the examination of the urine. We can check the color, specific gravity, then the chemical analysis will give you lot of information, then the microscopy. So by doing proper urine examination, we can predict where is the problem in the kidney. So it's another test that important to assess the kidney function. So the chemical analysis of urine, we initially done by the manual methods, but now we have the strip methods with impregnated reagent pads, and the automation of urine analysis also possible with these reagent strips. Then finally, we have come to the end of the talk. The important messages that you have to remember, even though the RFT or renal function test usually done by the creatinine and urea, those are not the only tests to assess the renal function. There is lot more other tests that indicate problems with the kidney. And creatinine may not be indicator of early renal damage, and urine albumin to creatinine ratio is a good marker to detect early damage. Then we can use the EGFR for the monitoring of patients with chronic renal failure and for the staging, and by doing so we can monitor those patients and arrange the proper treatment. And the interpretation of any laboratory report is always should done with clinical context of the patient and other investigation. Otherwise, the report will only a data. It's not, if we can just say it's high or low, looking at the reference rate, it's not the interpretation. So interpretation should always done with the clinical context of the patient. Okay, thank you very much. Any questions if the time permits?
Thank you very much, madam, for that excellent account on renal functions. Since we are behind time today, we will now move on to our next lecture. Body fluid reports always cause many dilemmas during laboratory practice. To discuss about the biochemical testing of body fluids, I cordially invite Dr. Tushari Vitanage, consultant chemical pathologist of Teaching Hospital Ratnapura. We can see you. I think you need to share the screen.
Can you hear me, Udara?
Yes, we can clearly hear you now. We can see the slides.
Good afternoon. I'm Dr. Tushari, chemical pathologist from Teaching Hospital Ratnapura. Today my talk is on fluid testing in clinical biochemistry. This is the overview, introduction, CSF analysis, serous fluid analysis including pleural fluid, pericardial fluid, peritoneal fluid, and saliva, seminal fluid analysis, and synovial fluid analysis. When we considering body fluids, most of the body fluids are ultrafiltrates of the blood and processed by the relevant tissues. So other than that, it can be a product of active transport also. Body fluids can be physiological as well as pathological. It can contain biomarkers which are not found in blood as well as at different concentration than the blood. For diagnosis of diseases, we can use biomarkers present in fluid like that. Presence or absence of a biomarker in a fluid or concentration of a biomarker, we can compare with relative to the health. Reference intervals are not established for rarer body fluid types, and we have to compare it with blood. When we consider CSF, CSF is a clear fluid in the space between arachnoid and pia mater, and it is formed in choroid plexus by both filtration and active transport. It forms around 20 milliliters per hour. In an adult, its volume is around 125 to 150 milliliter, and viscosity is equal to water. When we consider macroscopically, it's clear. Microscopically, normally it's acellular, but in adults, up to 5 WBCs and 5 RBCs can be normal. But in newborns, WBCs can be up to 20 normal. When polymononuclear leukocytes are more than 3, it's definitely abnormal. This is the composition of CSF. Mainly we consider protein, it's 15 to 45 milligram per deciliter in normal person, and chloride 115 to 130 millimoles per liter. These are the common pathological conditions associated with CSF: hemorrhage, meningitis, malignant tumors, and demyelinating diseases. Most important for us, specimen collection and transport of CSF. We usually collect CSF by lumbar puncture. We have to collect it mainly 3 tubes for microbiology, chemical biochemistry and cell count. Then the other tube, it's optional for the antibodies or electrophoresis or antigens. But the most important thing we have to remember is that samples should be analyzed within 1 hour without delay. The common biochemistry test we performed on CSF, mainly protein. As I mentioned earlier, in a normal person, CSF protein level is 0.15 to 0.45 gram per liter. But in premature infants and term neonates, it can be 0.2 to 1.7 gram per liter. Elevation of CSF protein can occur in infectious as well as non-infectious causes like obstruction. So, when we consider meningitis, after recovering from the meningitis, it will take several months to protein to get into normal range. So, we cannot use CSF protein level to assess the response to treatment. In Guillain-Barré syndrome, CSF protein level can be up to 1 gram per liter. Falsely elevated serum CSF protein level can be seen in presence of the RBC. That means approximately 0.1 gram per liter for protein per 1000 RBCs. The other common test we are doing is glucose level. Normal CSF to serum glucose ratio is 0.6. Ventricular CSF glucose level is usually higher than lumbar glucose level, and low CSF glucose level we can see in infections such as bacterial, mycobacterial and fungal, and non-infectious processes like malignancies infiltrate in CNS and subarachnoid hemorrhage, sarcoidosis. Usually, in normal viral meningitis, usually in viral meningitis, CSF glucose level is normal. But in meningoencephalitis, due to mumps, enteroviruses, herpes virus, herpes zoster, and lymphocytic choriomeningitis, it's not normal. CSF to serum glucose ratio is not useful in neonates and severe hyperglycemic conditions. The important thing is CSF glucose comes to normal when recovering from meningitis, first then CSF protein and cell count. The other important factor when we consider CSF is xanthochromia. It's the pink or yellowish discoloration of the CSF due to presence of blood in the CSF for at least 2 hours. When there is hemorrhage into CSF, RBCs get lysis and phagocytosis, then hemoglobin break down into oxyhemoglobin, finally to bilirubin, giving rise to xanthochromia. This is the picture of normal CSF and xanthochromic CSF. Xanthochromia first evident within 2 to 4 hours after bleeding into CSF. In subarachnoid hemorrhage, it can be present in 90% of patients after 12 hours of the bleeding and persist for 2 to 4 weeks. Other causes of xanthochromia are increased CSF protein level, usually more than 1.5 gram per liter, and systemic hyperbilirubinemia and traumatic lumbar puncture. We can visually confirm the presence of xanthochromia, but it's not very reliable. We need to do spectrophotometric scanning. To differentiate traumatic TAP from subarachnoid hemorrhage, we can use these three things. CSF finding, appearance and microscopy. In traumatic TAP, blood in initial tubes are high and progressively decrease in consequent tubes. In subarachnoid hemorrhage, blood is uniform in all the tubes. When a CSF sample allowed to stand in room temperature, clot formation occur in traumatic death, but blood does not get clot in subarachnoid hemorrhage. When we centrifuge and compare the supernatant in traumatic death, post-centrifugation supernatant is clear in traumatic death, but yellow or pinkish color in subarachnoid hemorrhage. The other important thing we met in clinical practice is CSF to differentiate CSF rhinorrhea from nasal discharge. Usually CSF glucose level is more than 30 milligram per deciliter, but in nasal discharge, it is lower than 10 milligram per deciliter. And when we compare chloride levels are a little bit higher in CSF rhinorrhea, that means 115 to 130 millimoles per liter. But chloride levels are low, similar to serum in nasal discharge. It's around 96 to 106 millimoles per liter. The most specific is beta transferrin 2. It's always present in CSF rhinorrhea and nasal discharge, it's absent. These are the findings in CSF meningitis. In bacterial meningitis, appearance is yellow, turbid, and polymononuclear leukocytes are markedly increased. Lymphocytes are slightly increased or normal. Protein markedly increased and glucose decreased. In viral meningitis, appearance is clear. Polymononuclear leukocytes are slightly increased and or normal. Lymphocytes are markedly increased and protein markedly increased or normal. Glucose is normal. In TB meningitis, appearance is yellow, viscous, and polymononuclear leukocytes slightly increased or normal, lymphocytes markedly increased, protein increased, and glucose decreased. In fungal meningitis, its appearance also yellow and viscous, polymononuclear leukocytes slightly increased or normal, lymphocytes are markedly increased, protein slightly increased or normal, and glucose normal or decrease. There are special tests we perform on CSF, immunoglobulins, IgG index, oligoclonal bands, and lactate. Normally, CSF contain very low amount of immunoglobulin. It's usually around 500 to 1. But if there is any increase in this ratio, it indicate any disorder that disrupt the blood-brain barrier, so it has little diagnostic utility. We use IgG index to differentiate the production of immunoglobulin within the CNS and if there is leakage from the serum. If the IgG index is more than 0.66, it indicates increased production within the CNS. So we can use oligoclonal band. Oligoclonal bands can appear in inflammation of CNS, any autoimmune disease or infections. Presence of 2 or more bands in CSF is a oligoclonal band. More than 90% of multiple sclerosis patients have CSF oligoclonal bands. When we consider lactate in CSF, usually it parallel with the blood level, but any biochemical alteration in CNS can cause to changes in the CSF lactate level independent of the blood. Increase of CSF lactate can be seen in cerebrovascular accident, ICH, and epilepsy. Also in mitochondrial disorders. Then I'm moving to pleural fluid. Pleural fluid is a ultrafiltrate of plasma. These are the mechanisms and causes of formation of pleural fluid effusion, but I'm not going to talk about because of the time being. The other biochemical tests performed on pleural fluid are usually total protein. We have to differentiate the pleural fluid is transudate or exudate. When we perform total protein, if it is less than 25 gram per liter, it's a transudate. If it is more than 35 gram per liter, we usually consider it as a exudate. But importantly, we use light criteria to differentiate a transudate from an exudate. Here we measure total protein and LDH level in both fluid and the serum. If the ratio of fluid protein to serum protein is more than 0.5 or ratio of fluid LDH to serum LDH is more than 0.6 and pleural fluid LDH more than 2/3 of the upper reference limit of the serum LDH, these three criteria we use for the diagnosis. If one criteria is met, we consider it as a exudate. When we consider light criteria, it's highly sensitive for the diagnosis of exudate, but specificity is low. False positive result can occur when the patient is received IV diuretics within 24 hours before the pleural tap. The other test we can perform on pleural fluid are cholesterol and pH. We perform cholesterol when there is uncertainty in the light criteria. Cholesterol cutoff level for the pleural fluid is 1.6 millimoles per liter. Usually cholesterol level is low in transudate than exudate. We can perform pH in pleural fluid, but we have to remember it should be collected anaerobically and we can do it on all non-purulent effusion. Usual pH is around 7.6. If it is less than 7.3, it indicates inflammation of the fluid. And if it is less than 7.2, that indicates that need drainage of the pleural fluid. When there is low pH value in pleural fluid, it indicates the poor prognosis. The other special test we can perform in special situation. If we suspect chylothorax, we can perform triglyceride level. Usually triglycerides are very high in chylothorax, more than cholesterol level. When we suspect TB, we can do adenosine deaminase. In malignant condition, we can do tumor markers. In pancreatitis, we can assay amylase. We have to differentiate chylous and pseudochylous effusion. When we consider chylous effusion, its onset is sudden and appearance milky white or yellow to bloody, and there is lymphocytosis. Triglycerides are more than 100 milligram per deciliter with cholesterol level less than 200 milligram per deciliter. In lipoprotein electrophoresis, we can see chylomicrons. In pseudochylous condition, onset is gradual and color is usually milky or greenish. We can see mixed cellular reaction with cholesterol crystals. Triglycerides are usually less than 50 milligram per deciliter and cholesterol more than 200 milligram per deciliter. In lipoprotein electrophoresis, chylomicrons are absent. Then we move on to pericardial fluid. Normally, pericardial fluid volume is 15 to 20 milliliters. It's also ultrafiltrate of plasma. And Pericardial fluid diffusion can occur due to systemic or local cause or acute or chronic condition. We have to differentiate that pericardial effusion is a transudate or an exudate. Usually we perform LDH and total protein level of the pericardial fluid and use light criteria as I mentioned earlier. But most of the time pericardial effusions are exudative. Rarely we need biochemical test. Then we move into peritoneal fluid. It's also ultrafiltrate of plasma. Normally in men it's 5 milliliter, but in female, depending on the pace of the menstrual cycle, it can be 5 to 18 milliliters. Peritoneal fluid also, if there's effusion, it can be transudate or exudate. These are the causes of ascites formation, but I'm not going to talk about it detail. When we consider the appearance of the peritoneal fluid accumulation, if it is normal peritoneal fluid, it should be straw colored or yellow tinge. But if it is cloudy or opaque, it indicates presence of neutrophils. And if it is milky or chylous, it indicates the presence of triglyceride. Non-traumatic peritoneal tap, if it is non-traumatic and appearance is bloody, it is malignancy or TB. And T-colored peritoneal fluid, we can suspect pancreatic ascites. We can perform other than that total protein. If total protein level of the peritoneal fluid more than 30 gram per liter, it indicates exudate and indicate the inflammation or malignancy. Amylase levels are high in pancreatitis, triglyceride are high in chylous ascites, and pH level less than 7 in bacterial infections. For the diagnosis of ascites, if it is to differentiate if it is due to portal hypertension or other cause, we can do serum albumin to ascitic fluid albumin gradient. If that gradient is more than 11 gram per deciliter, more than 11 gram per liter, it's portal hypertension. Then we can perform total protein level in that ascitic fluid. If it is low, that means less than 10 gram per liter, that's due to cirrhosis, alcoholic hepatitis, cardiac failure, or pulmonary hepatic failure. If the total protein level is high, more than 20 gram per liter, we can think of congestive heart failure, constrictive pericarditis, or Budd-Chiari syndrome. If the serum albumin to ascitic fluid albumin gradient is less than 11 gram per liter, it is due to TB peritonitis, chylous ascites, peritoneal carcinomatosis, pancreatic or biliary inflammation, like that. Then I talk about sweat. Sweat physiology. Sweat is an isotonic ultrafiltrate of plasma and it contains salt and urea but very little amount of protein and fatty acid. Then when the sweat goes through the sweat duct, salt is reabsorbed and sweat become hypotonic. When there is a mutation in gene encoding the cystic fibrosis transmembrane conductance regulator protein, it causes to dysfunction of the chloride channel and reabsorption of the chloride is diminished or abolished in the duct. In parallel to that, sodium reabsorption is also diminished. It results in more concentrated sweat. This defect can give rise to defective fluid secretion by the pancreas or lung. We perform biochemical test on sweat, mainly chloride. It shows better discrimination than sodium or osmolality when we are suspecting cystic fibrosis. So when the sweat chloride concentration is more than 60 millimoles per liter, it supports the diagnosis of cystic fibrosis. If the sweat chloride concentration is 40 to 60 millimoles, we can suggest but not diagnostic of cystic fibrosis. If it is less than 40 millimoles per liter, it's normal. When we consider doing sweat test For the patient should be more than 2 weeks of age and weight should be 3 kilograms. But exceptionally, we can do set test after 7 days of term infants, but there can be insufficient set production. Sweat chloride level can be high in underweight patient or dehydrate, as well as if there's a active eczema in the collection site. Low sweat chloride concentration can occur in systemic corticosteroid treatment as well as edematous patient. Then we move on to amniotic fluid physiology. It's a clear, watery and slightly yellowish contained in the amniotic sac and surround the fetus. Common test we perform on the amniotic fluid is bilirubin. It's high in hydroxyfetalis. There is a direct relationship between the gestational age, severity of the disease, and the bilirubin concentration. We collect amniotic fluid by amniosensitives and collect into a dark container and protect from the light. We have to centrifuge it immediately and analyze it. Then we have to spectrophotometrically scan for the amniotic fluid for bilirubin. Other tests we can perform on amniotic fluid are alpha-fetoprotein. It can be high in open neural tube defects or other congenital abnormalities like esophageal atresia, as well as acetylcholinesterase in when we suspect open neural tube defects. Then I move into saliva. In physiology, it's a mixture of oral fluids containing salivary glands, cellular components, and food debris. It contains molecules found in serum, which comes into it intracellular and extracellular routes. Salivary concentration of the analyte and volume can be affected by several disorders. It is directly affected by systemic disorders like Georgian syndrome, reduction in the secretion of the saliva. And it reflects changes in biomarkers in serum, like in malignancies, infections, and endocrinopathies. Exogenous substances also can be identified and measured in saliva, like drug. For saliva, there are several advantages using it as a specimen. It ease of collection as easy of storage. It's a non-invasive procedure. Most importantly, it's useful in pediatric patients and when we collect samples for the stress-affected hormones like cortisol. But there are disadvantages also, low level of analyte concentration when we compare to serum, and contamination from the oral cavity, and viscosity of the fluid, and collection is difficult in dehydrated patients. Biochemical tests we perform on saliva are antibody detection and viral particle detection in infectious diseases. In our biochemistry lab, most importantly, hormones. Majority of hormones enter the saliva by passive diffusion across the concentration gradient. These hormones are mostly lipid soluble and pre or non-protein bound levels. Like in cortisol, serum cortisol level is very well correlated with salivary cortisol level, except in very high levels of binding protein levels. Exogenous analytes like drugs can be detect and monitor, but the presence of drug in saliva depend on that drug's physiochemical characteristic and its size also. We can detect and monitor cannabinoids, cocaine, opioids, ethanol, diazepines, and amphetamines in salivary secretions. Then we talk about seminal fluid, spermatozoa in seminal fluid. Seminal fluid is made up of secretion of all the accessory glands of the male genital tract, and it functions as a nutrient support for sperms. These are the biochemical tests we perform on the seminal fluid, fructose. It's the major source of energy for the sperms. It's produced by seminal vesicles. And very low fructose level in azoospermic person indicate the absence of seminal vesicles and or vas deferens. Alpha-glycosidase and glycerylphosphorylcholine also can perform on seminal fluid. Obstructive azoospermia causes very low levels of these two analytes. And acid phosphatase in the seminal fluid, it's important. It presence in the seminal fluid, it indicates the presence of prostate gland. Then I move on to synovial fluid physiology. It's colorless. Its color is light yellow to highly viscous fluid, and it does not clot, and it found in joint cavities. It's also ultrafiltrate of plasma across synovial membrane. This is the physiology of synovial fluid. Color is pale yellow, transparent, uh, and when we consider cells, no RBCs, leukocytes less than 200 cells per microliter, and glucose very low, lower than blood, lactate less than 250 milligram per deciliter, total protein less than 3 gram per deciliter, and uric acid concentration is equal to blood. We can see increased volume of synovial fluid in non-inflammatory conditions like osteoarthritis, neuropathies, and inflammatory conditions like rheumatoid arthritis and gout, and septic conditions like bacterial or fungal infections, and hemorrhagic conditions like hemophilia and trauma. We can perform physical test on synovial fluid. One is strings test. It's simple test. We use viscosity. In a normal synovial fluid, when we drop it from a syringe, it forms a string greater than around 10 centimeter long. But in inflammatory conditions, that viscosity becomes low, and when we drop from a syringe, it drop like water, not forming a string. When we consider the appearance of synovial fluid, non-inflammatory synovial fluid is clear and yellow. Inflammatory synovial fluid or septic synovial fluid, it's cloudy and yellow-green. In hemorrhagic fluid, it's cloudy and red or red-brown color. And presence of crystal, it indicate by yellow or white appearance. Biochemical test we perform on synovial fluid, mainly glucose. There should be blood sample which was taken at the same time when you collect the synovial fluid sample. Synovial fluid glucose concentration is usually less than 0.6 millimoles per liter. Significantly low glucose level indicates septic or inflammatory condition of the joint fluid. There can be inclusions in synovial fluid. If you see pre-floating aggregates of tissues like rice bodies, it's due to rheumatoid arthritis or tubercular arthritis. But if you see ground pepper appearance, it's due to ochronosis. This is my references. Thank you. Hello, Dara.
Yes, Dr. Rajmal. Thank you very much for that very informative lecture on body fluid analysis. I'm sure our participants gain a good understanding of how to approach body fluid analysis. And at the end of this lecture, I would like to inform our participants that all the recordings of today's lectures and yesterday's lectures are available on our website. And the link will be sent to you along with the e-certificate and your feedback providing Google form link to you in the due course. So please go to those links and you can rewatch the lectures that we had during this session, in these 2-day sessions. So at the end of this successful online session, I would like to invite Dr. Tushara Hewagigana, our Joint Secretary, to present the vote of thanks.
Thank you, Dara. Let me take this opportunity to thank Dr. Sudath Dharmaratnam, guidance and support. Thank you very much, sir. I also thank all the speakers who presented in this workshop amidst of their busy working schedule. You took all the trouble to make your presentations fruitful. Thank you all. I would like to thank Dr. Udara Senaratne, Senior Registrar in Chemical Pathology attached to Colombo North Teaching Hospital, who involved in coordinating this event today. Thank you very much, Udara, for your support. I would also like to thank Mrs. Kasuni Gikianage, college coordinator, for her immense support to have the smooth run of this workshop on both days. Finally, I thank all the participants who join us from all over the country. Your participation was a great encouragement to us. Without you, this event won't be a success. And a lot of interesting things have been planned and scheduled for the months to come. So keep in touch with us. Thank you very much. Over to you, Dara.
Thank you very much, sir. So until we meet in another online event like this, we wish you a very good evening. Thank you all for participation.